Sir, you are live. Please start.
Sir, we are live. We can start.
Good evening, everybody. So this is Dr. Karthic Babu Natarajan. I'm a pain physician. I'm talking from Synapse Pain and Spine Clinic in Chennai, India. So first of all, welcome to all the delegates. When I saw the delegate list, I saw that some of you were from outside India as well. I saw registrations from Saudi Arabia, Bangladesh, UAE, Sri Lanka, and lots from India. So welcome to all the delegates and thank you for joining us. Now, I work in a clinic which is sort of multidisciplinary. So I'm basically an anesthesiologist. I do chronic pain as a full-time job. So we do a lot of interventional spine and we also do a lot of sports injuries. Now, as the dictum goes, this is a multidisciplinary approach. So obviously there are different modalities. There are surgical options, there are interventional procedure options, there is conservative management, there is a lot of rehab involved, there's a lot of psychology involved. So all of this is involved when we treat it. So I've tried to assemble probably the best team that's possible. So there are 5 speakers who are going to be in the panel today. So 2 of us are pain guys, and there are going to be 3 extremely well qualified orthopedicians who have kindly consented to join us. So I'm very grateful to them. So in terms of work, we do a reasonable amount of sports medicine work. We do treat patients who are elite athletes as well. If I'm right, the last IPL itself, we must have, procedure-wise I'm talking about, we must have done at least 3 shots for cricket players in the last IPL season. So we do a reasonable amount of sports work. So today's webinar is going to be on sports injuries management and stuff. To start off proceedings, I'm going to be calling Dr. P Kosygan, who will introduce you to the topic of sports medicine. Now, Dr. P Kosygan is a UK qualified senior orthopedic surgeon in Apollo Hospital, excellent clinician, and he's obviously the boss of our team. So he'll be introducing you to the topic. He'll be telling how managing sports injuries is different from managing musculoskeletal orthopedic conditions. And mainly, we will be trying to convey principles of sports injury management. We'll be trying to tell you when you do conservative management, when you do interventions, when you do surgery, and when you think of PRP, when you do steroids and that sort of thing. So essentially, it's more not a technical talk. It's going to be more based on how do you diagnose, how the principles of management of sports injuries in this part of India is going to be. So so we'll sort of divide the sequence into this sequence. So first, Dr. Kosygan would introduce you to the to sports medicine. Then we'll talk a little bit about shoulder sports injuries. So this is going to be by my colleague, Dr. Senthil KamalaSekaran. Then we'll talk about elbow and wrist injuries. Then we'll talk about upper limb interventions, which I'm going to be talking about. Then we'll go to hip injuries, then knee, then ankle. And finally, Dr. Vanmathy will be talking about PRP BMAC injections in hip, knee, and ankle. So the for the ankle and knee injuries, we've got an ankle and foot and ankle specialist, Dr. TV Raja, would be joining us. So he does exclusive foot and ankle. So his clinic is renowned for foot and ankle injuries. So he'll be joining us for foot and ankle injuries and to clarify your doubts. So to start off, I'm going to invite Dr. P Kosygan to introduce you to sports medicine, and we'll take it from there. You can start.
Now I have to put share screen. Yeah.
Share the share your screen.
You can see.
Yeah.
Yes, we are able to see Dr. Kosygan. Yes.
And I am unmuted. No, I have muted or.
No, you're audible as well.
Okay. Bye. Good evening. Thanks to the Synapse, Dr. Karthic, Dr. Vanmathy. We are part of a team here who deal with sports injuries as well as other orthopedic related problems. Thank to Intas as well, taking this nice step during this lockdown period to help us to share our knowledge and also interact with people from all over the world regarding something which is important in not only just pure orthopedic personnel, but also people who handle pain management issues or people who are involved in rehabilitation issues. Now, I'm just going to run through the first talk is just to give you a briefing about sports injuries, general principles, and then as individual speakers, we will touch on the some of the common as well as some tricky situations around various anatomical regions. And then, of course, the management part in this session will largely restrict to basic interventional procedures. Certainly, as the talk goes on and after the end of the talk, if anyone has any surgical questions, we will be quite, we'll be happy to take that and we'll address it individually. In most sports person, injuries are inevitable. And particularly when someone is there in the field for a long time, invariably you would have seen most big names were some time off because of injuries. And before this became as a specialty and before there was much understanding about why it happens, how to rehabilitate and when to let them go back to the sports, and also prevention is something which is developed over the years. So I would like to just to get in there gradually and to set the ball rolling. This is something very, very a fascinating piece of football in the history of football. And this was in 1998. And at that stage, it really went on to become one of the best goals ever in terms of, the top few goals. And by an 18-year-old English player in a World Cup. And I was watching this match live in my early days in England. And immediately comparisons was made to this guy is the next Pele, and he was only 18, And that was in 98, and he did have a very good career, and he went on to represent England more regularly. And within 8 years, he was actually in the bench following a sequence of injuries. And as you know, some of these injuries can be career-ending for some people. And this, as you can see, this knee buckled. It wasn't actually a direct contact or a tackle. Now, why this happened? Because he had injuries in between, and he did not give enough time to rehab before he went on to play this important game. The country needed him, and he knew he wasn't fully fit, and he went down. And that injury was very obvious. He did his anterior cruciate ligament, and from being a Ballon d'Or winner, from one of the best players in Europe, within 8 years, he had to be in the bench of a very basic district team. So just to set the ball rolling, it can occur in any sports, and sometimes even fitness exercises. And it is related to training, sometimes anatomical factors such as knock knees or flat feet, asymmetry, sometimes direct injuries, contact injuries, like in football, non-contact injury, and to some extent also to the equipment. As simple as sometimes even your shoes. if that's not right for the sports you're doing, it can affect, it can cause minor or major sport injuries. In training, overtraining is a common cause. In trying to achieve something within a short period, you have a set goals and you want to achieve it in a short period. And improper technique, for most professionals, this may not be a problem. For amateur sports people or people who take leisure sports, technique can be an issue. But for most professional athletes, they usually have trainers who guide them to the proper technique. Lack of conditioning. Now that again has improved over the years, whereby most of the people on the professional circuit are well trained, they have enough guidance as to that they should not start training without warming up or stretching. But still, when you go into the history of these people when they're present with injuries, it's usually one of these. And the common among them sometimes being overtraining. And this doesn't necessarily have to be high professional athletes. Sometimes even common people you encounter whereby they've started showing interest in a new sports or exercise, and they go on to jump to a different level within a short period. We don't have enough data, but certainly because nowadays lots of kids are taking to sports at a much younger age. Some are started, like for instance, the Olympic gymnasts, they start when they are 3 or 4. And the incidence of doctors' visits to sports injury close to about 500,000 in the US or the European population. And because quite a high percentage of people there participate in indoor and outdoor sports, as you're aware, even our region, more people are taking into sports now and a lot of other leisure activities. So we are seeing increasing number of people presenting to us with the various conditions. The other thing is they all start very early. Sometimes they're on the national or international scene by the time they're 12 or 13, 14 being the age when they're allowed. And so the immature bone and insufficient rest sometimes after a small injury can lead on to a bigger injury later on. And in certain part of the world, still poor training conditions are one of the contributory factors to these injuries. Why it's important? Because sometimes it can be career ending and their dreams, get shattered because they have to stop. They cannot come back after the injury, or if they continue, they may be warned that they can develop more severe problems. The second thing, of course, is the long-term degenerative disease. Sometimes you push on the affected joint. A lot of players have a target. They want to carry on for another year or two. They push on the affected joint and they can at risk of developing degenerative disease. I just looked at the number of various sports people I've treated, and almost in every sports there is a chance of getting injury. And as I said, I have not put fitness here, but certainly in most of your clinics, you would see people who are in a keen interest in fitness. They come to you because they've started some new exercises without proper instruction, without proper warming up and graduated training program. What happens? Overload or repetitive stress being the common, tissue injury. Tissue injury leads to inflammation. Inflammation leads to pain, and continued activity causes further tissue injury. And this is where we need to try and break the cycle. Pain is the initial warning symptoms in some people, or some people tell you that they're not able to perform at the same level. They're just finding it difficult to carry on beyond a certain point. We need to stop them there, because continued activity causes further tissue injury, and those are the ones end up in chronic problems. But whereas when they come to you at the level of pain, restrict the activity, reduce the activity, or modify the activity, allow the tissue to heal, they can get back to training again through proper rehabilitation program. And Yes, it can be direct, indirect, or overuse injury. Direct in most contact sports, indirect, in swimmers or in people who are involved in jumping, diving, and everything. And overuse, as I alluded earlier, is one of the common cause. And when you look at them, you try to ascertain, is it a bone injury, hard tissue, or a soft tissue injury? And accordingly, it will help you to decide on what type of imaging you need and what type of intervention you're going to give. Then according to the duration of injury, acute, as in you saw Michael Owen there going down on his leg, that's definitely an injured knee. And chronic, of course, is recurrent episodes of mild pain and restricted activity and gradually leading on to persistent symptoms. Now, there is a group in between whereby they have an injury, they've gone back without sufficient period of rest or gone back without allowing enough rehabilitation. Now, those are the ones which can go on to a more serious injury and almost can have a career-ending injuries. So roughly, these two terms which has confused me, and a lot of you out there may be wondering, sometimes we tell them, oh, it's only a mild sprain. Sometimes we tell them it's a strain. So generally, a sprain is something which involves the ligaments and the soft tissue around the joint. It can be just a stretch with swelling and pain, or it can be a complete tear or partial tear of the ligament. Strain, generally we refer to tissues away from the joint, particularly the tendon. It's a very, very powerful unit. The tendon is the one which imparts the force generated by the muscle onto the bone, onto the insertion site. So generally we refer to as a strain. The hamstrings, the calf, and the back being the common. The key to success, I put thorough history at the top of the pyramid, is you have to listen to them for at least a good 5 minutes or so, and then start your provoking questions. You can just listen to them. They'll describe the incidents, or sometimes they start off even years before when they had some niggles and how they ignored it or how they managed it. A thorough history is really important, followed by a physical examination. Just observe them for a while. Observe the affected part for a while, and then go by the usual look, feel, move, and special test. Most of the time, you've nailed it there. You've got an idea as to this is a soft tissue problem, a bony problem, it's an acute problem or a chronic problem. And then, of course, based on the sports, based on the common condition associated with certain sports, you're almost nailed it there. And then, of course, you go on to get the X-ray or CT or MRI or ultrasound or bone scan, depending upon your clinical findings. And the key thing is to identify early. Yes, particularly when it comes to professional sports, you treat them symptomatically in the first visit, but simultaneously think about how you can prevent, could this be an injury because of unaccustomed exercise or overuse? How can I prevent this person from getting something like this again and having a longer layoff? So physical activity is an important part of overall health. A lot of us encourage that. But at the same time, we need to educate them on the right training methods. A lot of people don't have any idea of nutrition. We do have a nutritionist in our clinic and suggest to some patients to take their help as to what is required for the sports they're involved in or the physical activity they're involved in. And using the proper equipment is always better. And if you don't have access to, you do need to see what best you can have access to and not use inappropriate gear or equipment. And in certain kind of sports, people should have a good break in between. And that's why even if you see in the tennis circuit, sometimes there is a gap of 2 or 3 months before the next major starts. And you do need to have adequate gap within a year. And adequate rehab. We do have very good rehab specialists. We'll certainly go through that later on. And again, I don't need any introduction to this man, who at the top of his career was one of the best in the world. And unfortunately, even he had a 4-year gap before he could get to the last majors. And at one point in time, it was felt he's never going to be the king who he was before. But a strong resolve. Finally, he decided to have a proper break, a proper rehab, graduated return, don't have short aims. And he did, after 4 years, get another big one. And in fact, after this one, it looked as though, in compared to all those titles he had before, he felt this was probably the best among his titles. And that's the joy when you can get them back to the sports as the treating doctors, the treating rehab person. If you can get them back to winning days again, it's much more sweeter than all the achievements they've had before. So education, the right kind of intervention for the right person, which needs a proper diagnosis in these people, and a proper protocol-based rehab. Sometimes it has to be tailor-made to this individual sports, to the individual's profile, and for adequate period. Adequate, I really emphasize adequate period. There's always a pressure. There's a major championship coming around the corner. They want to return early, but sometimes that can spell disaster. So resting between workouts, give the body time to rest and repair. Graduated rehab is very important. You aim for first strength, flexibility, and finally endurance. And listen to your body. For a day or two, continuously you're feeling some new signs of pain or discomfort, you're just not feeling the same way as you normally do, just get it checked rather than delaying it. With that, that's just a basic introduction to sports injury in terms of hard tissue, soft tissue, acute or chronic, various investigations. Emphasis on, you want to nail it, a thorough history, a good examination, and use the imaging appropriately. Thank you.
Thank you, Dr. Kosygan. So we were just introducing you to the topic. So I would like to now invite Dr. Senthil KamalaSekaran. He'll be talking on sports injuries involving the shoulder. So we just introduced you to the topic. Dr. Senthil, who's a senior consultant orthopedician from Apollo Hospital and Lotus Clinic in Chennai, will be talking on shoulder sports injuries. Dr. Senthil.
Share screen.
Full screen. Yeah.
Good evening, everybody. I'm Dr. Senthil KamalaSekaran, and I'm a senior consultant in orthopedics at Apollo Hospitals, and have my clinic facility at Chennai Ortho Clinic, which is a part of the Lotus specialty. Today, I'm going to talk about shoulder and knee injuries. I would like to thank Synapse Clinic to give me an opportunity to actually come and express my views on this problem, which is quite common in athletes doing overhead activity and racket sports. We are very well aware about the complexity and of shoulder problems, and how much of effort we need to put in to get these people right and back to sports. So as you see, it's shoulder injuries can be affecting any kind of age group. both the young players and the slightly elderly age group, when you start getting attrition in your muscles and tendons, you start getting more prone for injury. The main reason for the injury occurring is, as mentioned earlier in the introduction, is poor training. It could be poor nutrition. It could be poor technique. And ultimately, if these are not followed in the proper order, then you can land up with injuries. Many of the sports which involve throwing, like cricket, baseball, and others, you find that during the phase of the release of the ball, tremendous amount of force goes into the shoulder. And over a period of time, especially if you have people playing cricket and all, where you have the release, just before the release of the ball, you start getting problems in the shoulder, and many of them land up with tendonitis, or basically they land up with tears in the shoulder joint, which actually kind of cause problems, and they are put out from sport for a long period of time. So if you see the phases of throwing, it's mainly during the deceleration phase when the ball is just coming off, or when they are having the extension of the arm, abduction and extension of the late cocking phase, when they actually start developing real amount of problems in the thing. When you go up to, if in our country, if you see, many of us who are involved in playing cricket, then for them, if you see the phases of their bowling action, most of them, they go through this phase in which they actually kind of, initially there is a pre kind of stance in which they actually kind of start bowling. They go through a mid stance, and then they have the phase where they're actually having their rear foot down and the forefoot front. And then when the release action happens, then that's the time when they start developing problems. As in any other joint or any kind of problems, we need to get a proper history of how the problem started. We need to actually kind of ask them whether the injury has actually kind of triggered because of a fall, or was it because of any kind of activity during the sport, and what have they done actually for that, whether they met anybody, or is it because certain small problems, if left unattended, can lead to chronic problems. And then, as you know, the problem is best tackled when it's in the acute stage. Physical examination of the shoulder would involve not only examining the glenohumeral joint, the main joint, but would also involve examining the surrounding structures of the shoulder girdle. So that by that, what I would suggest is you would actually have a systematic kind of examination where you actually start off with the sternoclavicular joint, examine the clavicle region, examine the shoulder and the deltoid, examine the area surrounding the scapular region, the acromioclavicular joints, and then also you finish off the examination by examining the neck and also doing a neurovascular examination. So the reason I say that we have to do a neurovascular examination is many patients who actually land up with problems in the shoulder have problems in the neck region because of overuse. And so you have to examine the neck when you're examining the shoulders to realize that you can actually sometimes miss upon entrapment neuropathies or any kind of neurovascular problems which can occur in the arm. So as in any kind of thing, you observe the patient, look for wasting, look for any kind of other active thing. You feel the joint, look for any kind of deformities. And then we actually go for strength testing. And we also do special tests. Actually, in the shoulder joint, the main thing is when you can actually kind of pick up the clinical diagnosis by doing the special tests. My topic today, actually, I would be discussing mainly about cuff tears, rotator cuff tears, those kind of things, which actually kind of you see in the day-to-day practice, which people come with after an injury, and you actually kind of are able to give them some kind of a relief by actually looking and diagnosing it in the clinical setting so that you can actually kind of give them some relief afterwards. You also do get patients who actually kind of fall and have instability in the shoulder, so following a dislocation. And the process of how we actually kind of treat these kind of patients and get them back to activity. Investigations for shoulder injuries, we normally generally start off with simple investigations like x-rays. However, sometimes we do have to take some special views, especially if you are dealing with injuries which can have bony defects and those kind of things. We cannot take a proper view. You actually have to take other kind of special views. Arthrography is not used that much nowadays, but however, if you have a problem like if you want to suspect, if you want to investigate a person having a cuff tear, you by introducing a dye in the glenohumeral joint, and if you see any kind of seepage through a cuff tear into the subacromial space, you can actually pick up a cuff tear before they actually kind of go for any kind of a higher investigation like an MRI or a CT. CT is very helpful to pick up bony defects like a Hill-Sachs lesion or something. Also to assess the size of defect if you have a glenoid pathology, like if there is a shear off of the glenoid and if there is a fracture there, how much amount of reconstruction of the glenoid needs to be done. CT would give us a very good idea for that. So the first topic I would be discussing would be impingement, which is the earliest phase of the larger problem of a rotator cuff disease. So these people usually present either at the middle age group or the slightly elderly age group when they start having pain in the shoulder, and the pain actually kind of prevents them from actually kind of reaching towards their back. Some of them actually present with pain going down the arm, the deltoid region, and some of them actually have difficulty in sleeping. So night pain is quite high. So basically you need to get out this history from the patient, and if they are having problems in reaching their back, if they are having any kind of difficulty in lifting their arms, those kind of things, we need to think about the earlier phase of impingement. So the reason why they get impingement is when they lift their arm, they have an inflammation of the bursa, which is there protecting the humerus from hitching against the acromion process. Some people, if they are in the elderly age group, they do have a problem called with an acromion spur, which this kind of keeps rubbing against the tissues and causes attrition. So this kind of attrition, when it goes on, causes chronic impingement and severe pain. Treatment for these kind of injuries, what I normally do is, the treatment is conservative. I put them on a course of physiotherapy first to see if they are getting better. If they don't get better with the physiotherapy, then I offer them an injection of local anesthetic with steroid, or nowadays we actually even try PRP solution, the PRP injections to actually kind of relieve the inflammation in the region of the insertion of the supraspinatus tendon. However, if the problem is long-standing and if they find that they are not getting any relief with thing, then we are actually kind of offer a procedure called arthroscopic subacromial decompression, in which case we actually kind of help with releasing the sharp spur which is in the undersurface of the acromion, and that kind of relieves the pressure on the rotator cuff and prevents any kind of tear or progression of the tear. However, if the person presents to you with a condition in which he is unable to actually lift up their arm, either because of a fall or because of degenerative tear, then in that case, what we normally do for them is we actually kind of offer them a surgical treatment in which we actually kind of go for a rotator cuff repair, either by using bioabsorbable screws or metallic screws, and we actually kind of get the rotator cuff back into position so that they can actually kind of help in abduction of the arm and go about their activities. However, the rehab process for this is quite a tedious process in which we actually kind of immobilize them initially for at least a period of 3 to 4 weeks so that the tissues heal, and then we go about a graded period of exercise in which they actually kind of slowly rebuild the strength around the musculature of the shoulder and gain their full range of movements. The other injuries which can actually kind of affect the shoulder is instability. The instability is mainly occurring because of the people following, especially if they are having any kind of contact sports like rugby or kabaddi, when they actually kind of fall onto the outstretched shoulder, the anterior structures around the shoulder can actually tear, and the shoulder actually kind of dislocates. So anterior dislocation is the most common thing which we see. However, sometimes these patients can go back to normal activity if they have a single episode. We still advise them not to try to not lift their arm up and avoid certain movements like abduction, external rotation. In spite of that, if some people find that they are actually kind of getting a very lax capsule, or they have a problem in which their shoulders are actually kind of slipping out, then we do offer them arthroscopic procedures in which we actually kind of help with treating this problem by repairing the glenoidal labrum, which actually kind of rips off from the edge of the glenoid. So basically, if you have the glenoid, we actually kind of, if you see here that the glenoid, the labrum actually kind of has torn off from the glenoid rim, and the normal restraint of the shoulder. So the shoulder has certain restraints which actually kind of keeps the shoulder joint in the the humeral head in the glenoid region. If these restraints, one of which is the labrum, is torn, then the opportunity for the humeral head to slip out anteriorly becomes very easy. So the labrum has to be put back onto the glenoid rim to actually kind of make sure that the humeral head is actually in contact with the center of the glenoid and prevents it from actually slipping out. However, sometimes we also have a problem called a Hill-Sachs lesion, in which sometimes when the humeral head is actually slipping out, which actually kind of dents the humerus, in which there is actually kind of a small area in which the humeral head can actually kind of lever outside of the glenoid because of the defect. Based on this defect, whether it is actually kind of coming in contact with the glenoid or not, we actually decide whether it needs to be addressed or not addressed. The repair of the unstable shoulder can be either open or arthroscopic. Most of the procedures which we are doing nowadays for these are arthroscopic. And again, as I said, the rehab protocol for this is quite steep. And once we actually kind of have a very good fixation, most of them are actually kind of able to do most of the activities, including sports, once the tissues are healed after around about 4 to 6 weeks, and they have gone through a phased progressive rehab for the shoulder. This gentleman here on the left, many of us would be familiar with. This gentleman was actually in the peak of his career when he sustained an injury to his shoulder, and after that Sehwag was actually kind of unable to return back to high level sports. He was actually leading the Delhi team, I think, when he actually kind of in the IPL, when he was struck with this kind of injury in his shoulder. And he went to London, and the diagnosis they offered him was a slap tear of his shoulder. So basically, a slap tear is a labral tear, a superior labral tear, which is in the region of the biceps tendon. And these tears usually are diagnosed clinically by doing certain tests. And because the tests are actually, because the injury is actually kind of in close relation with the biceps tendon, the tests which we use for them are the tests which we actually kind of use for the identification of bicepsal tendonitis. So in the MRI, if you see this is a normal labrum. However, if you have a tear in the superior labral part, you actually kind of have you can see the fluid actually going in between the labral capsule on the top and labrum and the capsule on the top. and you can have a defect in the top, which is actually kind of prevents the shoulder from abducting very well and causes a lot of pain. So the tests which we normally use for the identification of slap tear or bicipital tendinosis is Yergason test, in which we actually in the Yergason test, we actually ask the patient to keep the arm in forward flexion, and we do a resisted supination. If the patient is experiencing pain in the region of the bicipital tendon, then we think in terms of bicipital tendinosis, or we have to keep the idea of a slap lesion in mind. The speed test is just like the Yergason test, but we just do forward flexion against resistance to see. The O'Brien compression test is not very, very specific for slap tear, but however, if you see that you keep your arm at 90 degrees of forward flexion, you fully pronate it, and you do resisted abduction to that, then and if you start feeling pain in the region of the shoulder, then you think in terms of a slap lesion. So the treatment for the slap lesion depends on whether the slap lesion is either a minor one, in which there is mild fraying, or if it depends on whether there is actually kind of a tear of the bicipital tendon, in which you actually think about actually kind of anchoring it back into place. So either it would involve arthroscopic debridement of the slap lesion, or it would involve treatment for the tear in the biceps tendon also. Other problems which we can have in the region of the shoulder, which involves the biceps tendon, would be biceps tendon subluxation. So this subluxation sometimes we can get in people who are into weightlifting, and there is lots of heavy weights involved, and the tendon can actually slip out of the groove in which it is positioned, and the transverse humeral ligament also there, which helps with the positioning of the tendon in the groove, can actually kind of get torn. And these people, when you abduct and externally rotate the arm, you can feel that the biceps tendon slipping out of the groove and going back into place. Usually these people, unless and otherwise this problem is really incapacitating, they normally get better with time, rest, and once the tissues heal. Obviously, if the patient has a tendon rupture or something, then later on we need to look into it arthroscopically to see whether you need to actually kind of do a biceps stenotomy, or probably even, or you might need to stabilize the biceps tendon with an anchor. The other injury around the shoulders, which we normally see with contact sports, especially following a direct fall on the shoulder, which could be again in any kind of sport, either being in football or anything where someone is pushed and they land on the shoulder, or even following a road traffic accident, would be a AC joint injury. Again, depending on the type of the injury, whether it could be a minor sprain of the shoulder where the acromioclavicular ligament and the coracoclavicular ligament are actually kind of sprained, we provide them just anti-inflammatory analgesics first if it is a very minor injury. However, depending on the grade of the tear, if there is a tear of both the acromioclavicular or the coracoclavicular ligament, and the displacement of the clavicle, how far away it goes from the acromioclavicular joint, or whether it can get even sometimes locked within the trapezius muscles, or anteriorly in between the clavicle and the subacromial region or subcoracoid region. Depending on that, and whether it's reducible or not reducible, we decide upon whether it needs to be managed conservatively or operatively. And most probably these ones in which it is massively displaced, we land up operating on it. We try to reconstruct the ligaments, and nowadays we have have techniques in which we do mini open fixations of these using dog bone fixation and other kind of devices. This internal impingement syndrome is normal, which is normally seen in throwing movements in which the posterior labrum is actually kind of involved, especially if the person is involved in abduction and external rotation movements too often. An X-ray will show a glenoid exostosis, especially if you do it in the abduction external rotation view. The treatment for this is usually, if the person is unable to externally rotate his arm because of the internal rotation deficit movement in the glenoid, they usually benefit from stretching of the posterior capsule. However, if these people do not get benefit from physiotherapy or stretching of the posterior capsule, then they do an arthroscopic release of the posterior capsule normally, and also address the causative area of pain, which usually is in the bicep, or it could be a slap pathology. Certain conditions which also affects the front and back of the shoulder is the muscles around the joint. The most common thing which we would see in weightlifters would be a pectoralis major tear. These people usually present with a concavity or a defect in the anterior region of the shoulder. They also have a lot of ecchymosis in the proximal aspect of the arm. Many of them are unable to do most of their activities after the injury. If the defect is really large and the pain is quite high, many of them actually land up having a surgery in which we actually have to repair the sternal portion and the clavicular portion of the pectoralis major, especially where on its insertion into the humeral groove. Deltoid tears are also common in weightlifting. People in the gym. Usually, most of the deltoid tears are not very major, and they actually kind of get better with physiotherapy and thing. As told earlier, we need to give them adequate time for the muscles to heal. Most of the injuries in the muscles take at least 4 to 6 weeks to heal. Some of them can take a longer time depending on the thing. And unless the patient actually kind of heals from the injury, it's better not to push them back to sports or any kind of other activity. Triceps rupture normally can happen in people who are having renal osteodystrophy or any other kind, or if they are having any problems with if they are on steroid use. Triceps rupture normally, if it is there, we normally have to repair it with anchors or doing primary fixation. Latissimus dorsi rupture can happen again with overhead activity or injuries. Sometimes they do require surgical treatment. And as I said, nerve injuries and entrapments should also be kept in mind when we are examining the shoulder, especially the suprascapular nerve, or we have the quadrilateral syndrome in which the axillary nerve could also get compressed, especially people who are carrying very heavy loads, those kind of things. So decompression of these nerves usually cause relief. And if the person is involved in any kind of boxing activity or anything, if they have injury to the long thoracic nerve, then we have to actually test for the winging of the scapula. And always it's a good idea to actually get the patient to remove the shirt and press the arm against the wall, because it's a very commonly missed injury. So I think with this, I would stop the topic on shoulder, and I would ask Mr. Kosygan to give you an idea of the injuries which affect the elbow and wrist. Thank you.
Thank you, Dr. Senthil. Can I now invite Dr. Kosygan to talk on elbow sports injuries?
Share my presentation.
Yes, Dr. Kosygan, you can speak.
You're seeing the screen?
No, sir, we are unable to. Yeah, now we are able to see.
See the presentation?
Yes, sir.
Okay.
Yes, sir.
Thank you, Dr. Senthil. Yes, we'll go on to the next part of the upper limb injuries, which is I'm getting some echo, which is also very common and can be quite debilitating. Yes, in 2017, he had a very severe pain in the elbow and he had to have a long layoff. And as you can see from his own statement, he consulted a lot of doctors around the world, and there wasn't any immediate surgical treatment which was available for his condition, apart from the fact he was told he needs to reduce its intensity of training and also give it adequate rest. A lot of these people, as you know from his case, he's had quite a few injury setbacks in his life, and every time he bounces back. And elbow injuries, virtually almost every sports can contribute to elbow injuries. Although the throwing athletes, weightlifters, people who do gymnasts, because of the hyperextension load, but almost any sports can contribute to elbow injury. It's a main fulcrum whenever you're trying to transmit the force from the elbow to the wrist, that this is the pivoting point. So an early diagnosis and treatment of such injuries is very important to enable them to return to competition as quick as possible. As we discussed in the first talk, yes, again, these could be acute, a single event, or a chronic repetitive strain. Now, what is important in elbow and knee is these injuries, the ones with instability and the ones without the instability, because your management, your assessment, and your management then has two perspectives. You need to know one, where there is pain and limitation in function and they're not able to perform, and there is the one where there is with and without. There's one with the instability whereby the treatment modality changes. And like other injuries elsewhere, it could be a single injury or a chronic repetitive strain. Now the other thing is, just look at the elbow from front, back, and side. So the two sides, the medial and lateral. Now, these could be enthesopathies, or these could be related to the ligaments, the medial ligament or the lateral ligament, or the medial tendon and the lateral tendon. And then the front and the back, again, posteriorly, impingement can happen. And also in the front, the biceps tendon. So again, you just compartmentalize whether the problem is going to be soft tissue, is it bone? Now, in addition, around the elbow, you also have to think about the nerve compression syndromes or symptoms. Keep them in mind, okay? Because when you ask them in the history, some of them, you ask them whether, do you also have some pins and needles, do you have numbness? Sometimes they say yes. But because sometimes when you have pain and swelling, that's how the arm feels. But you do have to keep them in mind about the nerve compression syndromes. And like the shoulder is akin to the hip joint, the elbow is also sometimes similar to the knee joint. Osteochondritis discans of the distal humeral condyle is also something you need to bear in mind when you're seeing younger athletes with pain and you're not able to get much out of your clinical examination. Because in the later talk, we are going to listen to some interventional procedures, and because around the elbow, mostly it is about in relation to the tendons. On the left is the normal tendon, the flattened fibroblasts, the well-organized the collagen, the type 1, type 3, and a tightly knit matrix, compared to the one where it's a rounded fibroblast, a fairly disorganized matrix in the collagen and increased ground substance. So just to show you a difference between the healthy tendon and a normal tendon and an abnormal tendon. And again, you will come across various MRI reports. You will come across various clinical reports where I say it's tendonitis, now it's tendinosis and tendinopathy. Now they are kind of a continuous sequence of events. The tendonitis is, as we know, is a inflamed stage where there could be swelling, pain, tender to touch, acute sharp pain, and generally because of the overload at the muscular tendinous junction at the insertional point. And you rest it at this stage, ice it, cool it, give the anti-inflammatories, avoid the further provocating factors, it might be fine. Now, then it can move on to a degenerative stage where there are some structural changes at the matrix and the collagen. The collagen becomes disorganized, it's not tightly woven anymore, and it can go on to the stage of tendinosis. And now this is a stage sometimes you may see some of these patients, and it's very critical. Now, what do you do and how do you take on from here can decide whether they can go back again to a normal tendon or they can go on to the next stage, which is a tendon tear or following a micro tear. It can be following micro tear. It can also lead to calcification and fibrosis and a stiff tendon, and recovery may be quite not possible. The pain may settle, but functional recovery may be quite challenging. So yes, an acute injury, if you give adequate rest, it goes on to healing and effective tendon healing, and then you got to have a graduate rehab program, and they will be able to return to their previous level of sporting activities. Now, if there's insufficient rest, insufficient rehabilitation, then it goes into re-injury, and then it becomes a chronic injury, fibrosis, and stiffness. I want you to bear that in mind because you may get them at the tendinitis stage or a tendinosis stage, and what you do makes a difference. And I'm not going to go into detail, just to show you that almost virtually every sport you can imagine can contribute to elbow injury. It is just not the weight training. It is just not the racket sports. Interesting in this list is football. You know, sometimes you can see them. They really use their dominant arm to push against the next player. So virtually any sports can lead to elbow injuries. Again, two famous sports personalities, and as you know, Tendulkar had a lot of treatment for his one of the common condition around the elbow, which is the lateral epicondylitis, or what we call the tennis elbow commonly, not necessarily tennis players. And of course, don't not to miss the housewives and the what I call the young mother's syndrome, because they carry the baby in the dominant arm, and they quite commonly come with a pain around the elbow. Now, this is a repetitive contraction of the wrist extensor, the common extensor origin at the lateral epicondyle, the ECRB, and the rest of the muscles. So it's a traction injury. Of course, racket sports, weightlifting, and throwing athletes are common and quite easy to diagnose. You press on the painful spot. Most of the time is on the lateral epicondyle. You may be sometimes caught when the patient says the proximal forearm where it hurts, but as you trace upwards, you come to the most painful spot. And then you realize, okay, this is what they're trying to explain. Okay, this is not the forearm pain. It's not the pronator syndrome. It's not the brachioradial syndrome. It is tennis elbow, which is by and large common. And then, of course, you do, for the tendons, you do a provocative test where you do test the tendon against resisted line of action. So you do the wrist extensor or the finger extensor against resistance, and if you feel the pain at the top end, it confirms the clinical diagnosis. Diagnosis is mostly clinical. Sometimes in patients with elevated uric acid and in people who have repeated repetitive stress injuries, you can see a calcification on the radial side. Not always common. Ultrasound is fairly okay in the tendinitis stage, where you see the swelling around the tendon and fluid around the tendon. But of course, if you can have access to MR is the best, particularly in the high-level athletes where you want to plan your next level of treatment, and you can see the changes between the periosteum and the tendon with the fluid, and also in this case some early degenerative changes or tendinosis changes happening in this case. Treatment, it can be as simple as just asking them to stay away from the provocating sports, not to lift the weight on the side, give it enough rest, ice cold fomentation. And I use a combination of laser and ultrasound therapy, the laser followed by ultrasound, and counterforce bracing, simple tennis elbow support. Want them to wear it most of the time, particularly when the hand is in use, preferably even if they want to, preferably even when they're sleeping. And of course, they can unwrap it now and then, apply it, and also tell them to put it in the at least 3 centimeters below the elbow crease, right, not on the elbow, just a little below it. What you're trying to do is to block the force generated by the common extensors onto the painful site, onto the insertional site. 2 types of injection, which Karthik and Dr. Vanmathy will go in detail later. And if it's inflamed and I only want to treat the pain, I go for the corticosteroid. More and more, I'm leaning towards PRP. When I see them, the tendinosis or the tendinopathy changes, I avoid steroids. In fact, one of my earlier publications is around a hole in the common extensor tendon, which I published in 1998 in Journal of Sports Medicine, was inadvertent steroid injection around the elbow site, and it got a big hole which we have to repair it. And surgical is by and large rare. You all know about Tendulkar did have surgery, but then subsequently he actually rehabbed, changed his batting technique and the way he played some of his shots, and that's actually what helped him. In fact, one of the advice came to him from a waiter at the hotel he was staying, and he changed the way he was playing some of the shots. So surgery is not always a absolutely rosy path for this situation. Try to treat them with injections and brace them and rehabilitate them. Of course, if it's ruptured, you have to repair them. The other side, you go on to the medial, to the lateral side, the golfer's elbow, the hyperpronated flexor pronatus, which puts a massive strain, is the swinging arm. The lead arm is the left arm in this case. The power arm is the right arm in this case. It's a pronator, flexor pronator. It's a common flexor origin, putting a traction injury at the medial epicondyle, and common in the pitchers and golfers and weightlifters. Again, when you probe them, they might say, yes, they do have some pins and needles. So do examine for ulnar neuropathy, ulnar neuritis, do the Tinel's test, and check for any associated neurological symptoms, and also the olecranon bursitis. There may be a swelling around. Check if the swelling around the bursa or the swelling is actually more around the common flexor origin. So, like the provocation test for tennis elbow, here you try to flex. There you dorsiflex, here you palmar flex, and pronate the arm in about 30 degrees of flexion. And you can provoke, if the pain is reproduced, then most likely it is from the medial epicondyle. And again, you can probably sometimes see a sliver of calcification around the insertional site, but not always. MR is useful. Somehow I find the predictive rate is not the same with ultrasound with regards to the golfer's elbow as it is with the tennis elbow. So preferably an MR is better. You will also be able to visualize any thickened nerve around. So I prefer MRI in most cases as possible. It's the same brace which you can use. There are some other types of brace also available. Essentially, again, you're trying to block the force going on to the insertional site. So counterforce bracing, and essentially the treatment protocol or modality is the same. Proximal ruptures, Dr. Senthil alluded to this in his talks earlier on. Distal bicep rupture is rare, but is common in people who do weight training, and if you probe them very carefully, at some point in time, there may be an history of steroid intake, which they may not accept to initially, but they may say, I don't take it now, but I used to take it before. I used to pump weights, and there is it's usually an arterial rupture. Otherwise, in people who do a graduated weight training and who are in particularly these all models and others, they usually have strong biceps. It is most of the time an arterial rupture, and sometimes secondary to use of steroid use, which causes some degeneration. So it is a rupture on a pre-existing tendon micro tears or a pre-existing tendon degeneration. 97% of proximal. Okay, so it's an eccentric extension load applied in a flex supinated forearm. The people who pump weights and also do push-ups and those kind of categories. The classical Popeye sign with ecchymosis, the retraction of the muscle proximally, and the MR here. And you can see this is not a very, very healthy looking tendon which is just snapped as though you slice with a knife. No, there is a degeneration of tendinosis changes in the distal biceps tendon. Okay, sorry if you've not heard me clearly. And in young, active, and particularly weight trainers and these models, the Mr. World, the Mr. Universe, I guess better to repair them early when the tendon edges are fresh. But in people who have degenerative changes and they're really not back into competitive sports, they're only part-time, they're doing fitness part-time, you can even leave it. But in most cases, a distal rupture, we tend to fix it surgically using the buttons. You do an end-to-end repair if it's further higher up, but if it's at the bony interface, you need to use something like a endo button to pull it through the tunnel in the bone. As I told earlier, if anyone is interested in the surgical and other rehab thing, we can have another session. We're just going to go through the basic conditions in this session. And in a very young athlete, it could be a season-ending injury. It takes at least minimum 4 to 6 months when they can go back to weight training and perform to their previous level of efficiency. As much as in the front, as I told you, you look at the medial, you look at the lateral, look at the medial, look at the front, look at the back. And the back, the triceps tendonitis, people who do weight training against gravity, they do pump weights against gravity. In sports, which involves hyperextension of the elbow, repetitive extension, the throwing athletes, weightlifters, and these are common, and they usually present to a pain around the back of the elbow. Again, you do need to look at whether there is any boggy swelling around the olecranon. As Dr. Senthil said, we all have a bursa at the tendon-bone interface. The bursa generally protects the tendon against these frictional loads. So you do look for olecranon bursa, but proximally further higher up is where these patients complain of pain, and it could be micro tear or it could be inflamed in the tendinitis stage. And yes, you can sometimes see a bony spur. So don't forget the olecranon bursitis. Almost most of these respond to rest, NSAIDs, and of course, a sort of cortisone injection if you want to give them some immediate pain relief. And most players are able to continue to play once they've gone over the acute phase. Tricep avulsion is rare but can happen. So if you see a flake sign, when someone is coming with elbow pain, if there's a flake sign, it's a triceps avulsion. When the bone is strong, avulsion is rare. When the tendon is much stronger than the bone, avulsion can happen. So it should immediately alert to you why in this person, again, steroid use can be an underlying factor for which you need to probe into. And of course, in the elderly, it's a different issue. Some people start training only in the 60s. They take to some leisure activities of fitness at a very later stage in life, and they can also have this. Not necessarily related to a young athlete always. A conservative treatment, you just immobilize them in 30-degree flexion, and then you slowly rehab them. In a young athlete, however, if the sliver is big, you should try considering pinning it, because they are expected to go back to high-demand sports. But if it is a young athlete, generally they're again looking at least 6 months before they can go back to being able to put a hyperextension load on that elbow. The common things are common. See, tennis elbow, most of you can pick it up, and also the medial epicondylitis. But sometimes this posterior pain, as I said, it could be a Triceps Tendonitis, it could be an avulsion, but this is not uncommon. If there's someone in the throwing athlete or in a sports where there's a hyperextension, such as the gymnast, and a sudden jerk, such as in the weightlifters, they can develop something called the olecranon impingement syndrome, which is hyperextension valgus overload syndrome. Again, posterior pain, loss of terminal extension. They can, but they're not able to hyperextend. Remember, some of these athletes need to really hyperextend, the gymnast, So, and as I told you initially, elbow problem with instability, without instability, because there's a lot of load in this gymnast, and some of them do have some hyperlaxity. You do need to check for any collateral ligament laxity in posterior impingement pain. Are they blocking the terminal extension because of the instability? Are they blocking the terminal extension because they have impingement? And you can sometimes see loose bodies in the X-ray. And again, in as much as possible, in these highly competitive sports people, you do better to get MRI. Can physiotherapy and rest it, ice it, anti-inflammatories for the pain, and these high demand sports athletes, they do push you to get the maximum extension possible. So there is a little bit of low threshold for an arthroscopic or open debridement of posterior fossa to remove those loose bodies to get that terminal extension, provided their collateral ligament is intact. If the collateral ligament is also in doubt on the MR, clinically, you need to debride as well as reconstruct the collateral ligament, because this extension and hyperpronation is involved in these individuals. See, the 3 bands of ulnar collateral ligament, this band is very, very important. We all think this is the one which is just something happens to the ulnar collateral ligament. Okay, you do a valgus stress, there's laxity. This is equally important for the stability of the proximal radio-ulnar joint, because this goes like the MCL. You can rest it and it may heal, or you can even repair it. But when this goes, there is instability at the proximal radio-ulnar joint, and that's why when you explore these elbows, you do need to be careful that you are not causing any damage to this part of the ulnar collateral ligament. And common in the pitching and throwing and racket sports, and it's a gradual onset pain, sometimes medial elbow pain, which sometimes they tape it or they brace it and continue with the sports, and then one fine day it gives way. And you can try to reproduce the pain by doing a valgus stress test, and also see whether it's opening up, both clinically and on the X-ray. So MR is useful, and if it's a complete tear, you need to consider surgery. The little leaguer's elbow is in the adolescents. It's a transient weakness of the epiphysis in the adolescent. And some of these athletes are 12 or 13 when they take to high intense sports. And I just go on to the saying, the other one is the medial pain. You can see just where the epiphysis is, and then you can see an edema on this one. They come with a point tenderness at the medial epicondyle and pain with valgus stressing. On pain with valgus stressing, you have to check whether it's opening up or not opening up. It's not opening up, it is only pain without instability. So all you need to do is just give them rest. It's an adolescent, they're still in the growing period, the physis is not completely fused. So NSAIDs, rest, bracing, and then when they're fully recovered, you can let them go back to playing. And with strong resolve and proper management, he's a great example where you can come back repeatedly after injury. Although he was written off almost in 2017 with that elbow injury, he came back in 2019 strongly, just winning 3 out of the 4 majors. And again, I'm sure a lot of his physicians and rehabilitation team contributed to his recovery. So elbow pains are common. Identify them earlier. Look medial, look lateral, look front, look back. Use your appropriate investigations, and then plan your treatment. Thank you.
Extensive talk, beautiful talk on elbow pain. So I thank Dr. Kosygan and நீங்க வந்த screen. Don't share it. Okay. So now that we talked a little bit about sports injuries and how we manage sports injuries, I'm going to touch upon some of the common interventions that we do. So I'm sure majority of the audience are pain physicians, so you have some idea as to what sort of injuries we are talking about here. So the first dictum is majority, since some of you are pain physicians. So the first dictum, which I would like to stress to my pain physician colleagues is, some of these things may go over your head. So this is not our job to diagnose accurately and identify them with MRIs and treat these patients. So if you're not able to diagnose, the bottom line of the thing is it's multidisciplinary. So don't hesitate to take the help of your orthopedic colleague or somebody who specializes in sports medicine. So we work as a multidisciplinary team. So I do see these patients, but if I'm not sure, I don't hesitate to take the help of one of the orthopedicians or somebody who's better than me. So teamwork always does better. So what's special about sports medicine is, see, sometimes as a physician, when you see these patients, we do see musculoskeletal injuries, and a lot of times you can manage them conservatively. You ask them to do the rise or the price where they do the rest and the compression and elevation and icing, and so they do come around. But the thing with sportsmen is sometimes time is a factor, because there is always pressure on the physician to make them all right better, because you want them to go back to action fast. And also these people are very precious. So you don't want to bugger it up. You don't want to take too much time. At the same time, you want to be on the safe side. So you want to keep these in mind when you're treating sports physicians. So one is, you don't want to miss a diagnosis. So my way of looking at it is, if you're not sure clinically, I wouldn't hesitate to order the extra investigation. I wouldn't hesitate to order the MRI. Second is, if you're not sure, take help. And the third is, make sure you've got the diagnosis right, and make sure that they go back to action fast. So these are things that you want to keep in mind when you treat sports injuries. Now, we do see patients with the ligament injuries and muscle injuries. So just to give you an idea, this is the British Athletics muscle injury classification. Just to give you an idea, what's grade 0, grade 1, grade 2, grade 3, grade 4. So majority of the time, grade 4s and sometimes even grade 3s, we end up doing surgical repair. Grade 1s is where we do conservative management, and the injections come in somewhere between 2 and 3. Again, some of these injuries may be myofascial, some of them could be musculotendinous, sometimes they could be intratendinous. Now, always remember, majority of the time, the trouble happens in the musculotendinous junction. So as much as possible, try to focus in the musculotendinous junction. That's where majority of the time people do get injured. So that's something that you want to keep in mind. And obviously, the patient is going to guide you as to which is the most tender spot when you are assessing. The other ways of classifying muscle or ligament injuries is this one is by Otto Chan. So again, the grade 1, grade 2, grade 3 being strain, partial tears, and complete tears. Just to give you an idea. For majority of these classifications for you to do, you will have to do a MR. So very difficult to do this just with an ultrasonogram, even though we do find that ultrasonogram is readily available and it may be your first imaging modality of choice in treating patients with sports injury. So yeah, we do grade them as 1, 2, 3, 4, depending on how bad the tear is. This is the Munich consensus of muscle injuries. So just some things that you want to keep in mind as a physician when you're treating. There is a possibility that you are trying to identify this with ultrasound or MR. So if you're seeing these at a very early phase, that's like less than 6 hours, the MR is probably a better imaging modality than ultrasound. So for detecting things like muscle scar detection, the ultrasound may be better than the MRI. But for majority of the things, the MRI is a better option. So the ultrasound is definitely useful, and the usage of ultrasound for diagnosing and treating sports injuries is ever evolving, and the role of ultrasound is increasing all the time. The big advantage being that you can have it in your OPD, you can have it beside you, and you can just scan it, and you can pretty much know what's happening. But again, when you're treating sports men, 2 things. One is you don't want to miss the diagnosis, and these people are very precious. So don't hesitate to go for the MR. Right. So in terms of injection, so there are 2 options, obviously. So you have a role of doing steroid shots, you have a role of doing PRP or BMAC shots. So the corticosteroid shots are essentially something which you do in tendonitis. So as you see that, if you see somebody with, let's say, something like a golfer's elbow, if you see at the microscopic level, there are micro fractures in the tendon. So essentially, when you do a steroid shot, you're suppressing the symptoms, you're suppressing the inflammation, but you're not essentially enhancing healing. So steroid shots in the long run are not a great idea. So as time goes, it's possible that the regenerative medicine will totally take over, and the steroid shots are pretty much gone. The role for steroid shots is mainly when there is acute inflammation and edema that's happening, and also when you don't have too much time. It's possible that sometimes there's a bit of pressure in terms of time, so that's the only rationale for doing steroid shots. As time goes, the regenerative agents like PRP and BMAC are taking over steroid shots. The essential difference in technique being that the good old days when we did steroid shots, we were using it around the tendon. So when we do PRP, try to remember that when you're doing a PRP shot, we try to get into the tendon and we are trying to inject into the tendon majority of the time, which is the difference with the steroid shot. When we do a steroid shot, we do it around the tendon. So PRP we do extensively with more and more evidence that's coming up for musculoskeletal injuries, for sports injuries. We do find that these agents work wonderfully well. And we use 2 types of agents commonly in India. We use platelet-rich plasma. We use bone marrow aspirate concentrate. Essentially, we take about, it's about 10%. So if you're taking about 60 ml of blood, you're going to get about 6 ml of PRP, and about 30 ml of blood, you're going to get about 3 ml of PRP. You do a double centrifuge depending on which kit you're using. Majority of the time, we end up using commercially available kits. So we do take these samples under sterile precautions, do a double centrifuge, and get the PRP. So multiple kits are available, so you can use whichever kit that's convenient to you. So why platelets? Because it contains all sorts of growth factors. So essentially, it enhances healing and make sure the growth factors are there. So in the long term, even though the waiting period for steroids is more, but these results give amazing. The results are quite amazing. So in our practice, we use PRP extensively for musculoskeletal conditions, sports injuries, and our results have been pretty good. So yeah, this is the kit that we use in the clinic. The other option is when we use bone marrow aspirate concentrate, essentially the difference being that we aspirate bone marrow from the iliac crest. Now we choose BMAC when we think the injury is more extensive, when it's more grade 3, And very commonly you find supraspinatus tears where you find that the anterior and the superior part are almost torn, and just that some of the fibers are sticking together. So if the tear is more extensive, that's when we think of doing a BMAC injection. Majority of the time we may do a PRP injection. And again, PRP injection, sometimes when we do the injection, there's a possibility that we tell these patients that you may require a repeat shot. But usually when you do a BMAC injection, which is a little bit more extensive and expensive procedure, we end up doing only one injection of BMAC. So this is a BMAC injection. We take it from the iliac crest and do a centrifuge, and then we take about 60 ml of bone marrow aspirate, and then we get about 6 ml of BMAC injection, which we are injecting into wherever there is a pathology, which is a tear, under ultrasound guidance. So yeah, so we do see shoulders, elbows, and wrist in elite athletes. So just to give you an idea, Dr. Senthil talked about extensively about a lot of shoulder conditions. The ones that are surgically correctable, which require arthroscopic repair, are the ones that go for arthroscopic repair. The ones that require injections include things like rotator cuff tears, supraspinatus tears, bicipital tendonitis, acromioclavicular joint involvement. So essentially, tendon ligament injuries are ones that we do injections. So you can see here, this is an acromioclavicular injection. So obviously all these injections are image guided, so you can see the AC joint pretty well, and then you can go ahead and do the injection. I'm not getting too much into the technique of the injections itself. You can see the bicipital groove there, and the long head of the biceps is there. You can do this in short axis and long axis depending on how comfortable you are. And essentially, when you did a steroid injection, you injected around the tendon, and when you do a PRP injection, you can inject around and into the tendon. And essentially, you will know that there is a bit of inflammation there by the surrounding edema. Sometimes it's possible that you aspirate the edema. Sometimes when you put on Doppler, you'll find that there is increased vascularity, and sometimes there's a loss of architecture. So this gives you an idea of where the tendonitis is. The other direct way of doing it is ask the patient and check for tenderness. So he will point you to where the point is. So bicipital tendon injections, that's something that we commonly do. Supraspinatus, we do see supraspinatus tears. Partial thickness supraspinatus tears is the one where there's a role for PRPs. For the complete PRP, the supraspinatus tears, we go in arthroscopically and do a surgical repair. So we get very good results, lots of positive evidence for rotator cuff injuries where we do treat them with PRP. Sometimes we require repeat shots of PRP. So usually it takes about, let's say about 2 ml of autologous PRP for the supraspinatus, and obviously it's image guided. So this is one of our procedures here. So this is, I think in Apollo. So this is the patient here. So we are targeting the right side shoulder under sterile precautions, under ultrasound guidance. You can see that I've already taken blood. So that's about 3 ml of PRP in my hand. So I got the ultrasound under sterile precautions on my left hand and the PRP in my right hand. You can do this in a supine patient or in a patient who is lateral. Supine is slightly easier. And you can see that I'm having the ultrasound on the other hand. So you sort of have an idea, and we have done a significant number of supraspinatus injections, and our results are very, very, very promising. So very encouraging for rotator cuff tests. Coming to the elbow, we do see lots and lots of sports injuries in the elbow, essentially because of what we talked about, thrower's elbow. So we do see multiple things, but I'm going to stick to what we do see. Commonly, we see a lot of tennis elbows and golfers' elbows, other than the conditions that I've mentioned. So tennis elbows, we do the initial conservative management, which includes rest, icing, compression, and elevation. So obviously use the band, rest, icing, compression, along with the short course of NSAIDs or COX-2 inhibitors. The ones that don't come around with conservative management are the ones that we think of injection. The good old days, we did the steroid shots. Now we find that the PRP shots, we get amazing results. So majority of the time for tennis elbows right now, we end up doing PRP shots. Under image guidance, do the injection and inject below the tendon, between the bone and the extensor tendon, and a bit into the tendon itself. So that's we get good results with PRP shots for tennis elbow. Similarly, we also do PRP shots for golfer's elbows, even though it's probably less common than tennis elbow. Individual muscles, we talked about partial thickness tests, about other muscles like triceps, biceps. There is a role if conservative management fails in muscle injuries in partial thickness tears that we do PRP injections. Again, majority of the time we come around with conservative management. If it is an extensive tear, we have to go in and correct it surgically. Coming to the wrist, we see multiple injuries in the wrist. The ones that we see commonly are the decurvents. So decurvents, you can see the tendon under the ultrasound guidance, and then do, it's possible that you can aspirate the edema. You can do most commonly in decurvents, we end up doing a steroid shot, but there is a role for doing a PRP injection in the decurvents also. The next common one that we see in the wrist is probably the triangular fibrocartilage ligament. So the TFCC injuries we do see, especially in racket sports, we do see them in tennis players, we do see them in shuttlecock players. So TFCC injury is quite common. So we do, the thing with TFCC is you need a good clinician who identifies it for you, and you confirm that with the MRI. You do the conservative management with rest, icing, compression, and elevation. And if they don't come around, you have to consider a PRP injection. And our results with TFCC PRP injections have been pretty good. So I just touched upon what are the common conditions where we do injections in the upper limb. There are other conditions as well. But again, if you are clinically diagnosed them correctly, confirm them with the MRI, done a conservative trial, and we do get good results with pain interventional procedures in the upper limb. So thank you. That's the end of my talk. So we have sort of started with sports injuries. We have seen a bit about shoulder, elbow, and wrist, and we talked about interventions in the shoulder, elbow, and wrist. So we'll move on to the lower limb now. So we'll start off with sports injuries involving the hip, then we'll go to the knee, we'll go to the ankle, and then we'll talk about interventions that involve them. And finally, we'll take questions. So meanwhile, if you have any questions, feel free to put them in the comment section. So now I'm going to invite Dr. Kosygan again to talk about sports injuries involving the hip joint.
Karthik sir, you have to stop sharing your.
Yeah.
Yeah.
Is that, can you see that?
Yes, sir. We can see and hear you, sir.
Good evening. Thanks once again. I'm just going to touch about sports injuries on the hip as we start the lower limb session. Certainly, if I'm going to stretch like this, I will definitely do my adductor and my shoulder tendons. And I think some of these people are really flexible, but others sometimes go to the various fitness programs and they try to emulate people who are already doing emulate people who are already there, and sometimes they overstretch and get tendon injuries. Now, a hip being a joint which is deeply located, a lot depends on the history. You really need to ask them to pinpoint. They do this typical C sign. They'll put one of the thumb on the front of on the back of the gluteal region, the fingers in the front, and they'll say, this is where it hurts. It's called the C sign. They just grab the hip and say, this is where it hurts. And when you probe further, you can ask them to point whether it is around the SI joint, is it around the side of the joint, is it in the front of the joint. So again, like the elbow, like anything, history, and making them pinpoint where exactly the pain is quite important to nail the diagnosis. The front of the joint, the side of the joint, or the back of the joint, what aggravates the pain. Now, sometimes they say the pain is at rest. Now, if something is structurally deranged, something is structurally abnormal, then you would actually expect a mechanical pain, right? So you need to ask them what causes the pain. Is it pain with activity, pain at rest? Now, that would then make you think whether if it's pain at rest, and if it's pain actually without the movement of the hip joint, whether is it a referred pain. Now, you do need to think about the spine, and you do need to think about any intra-abdominal causes. Okay. Now, some of these problems around the hip can be related to childhood hip problems, such as Perthes, such as CFE, subcapsular epiphysis, or Perthes. So, a childhood history is important, whether they've had any problems during childhood. And the other thing which you can see is not necessarily for enhancing their performance. Some of them could be asthmatic, some of them could have had the use of steroid in the past. So you do need to ask them about any use of steroid. Now, again, the next thing is about, is it from the joint? Is it from outside the joint? Okay. So in the joint, yes, of course, whether it's in the cartilage, the labrum, or any degenerative changes, or any loose bodies. Now, if it's outside the joint, is it from the trochanter? Is it from the tendon? Is it from the ligament? And of course, you do need to think about the snapping hips. Sometimes they say it doesn't necessarily hurt, it's discomfort, but they get to hear a popping noise every now and then and with certain movement. And it could be quite tricky unless they're able to reproduce it. Some of them come back and they show you how to reproduce it, but it could be otherwise tricky. So again, you just need to ask them to reproduce that. In which moment does they get the snapping noise? And then you have to decide whether it's intra-articular or extra-articular. Okay? And as I told you, it's a C sign on the back of the hip and the front of the hip. The back of the hip, the common area being the SI joint. Some of them are overexercised, and some of them they go for a massage and everything. So keep the myasthenic ossificans in your mind. Trochanteric bursitis is by and large very common. Pain on the side of the hip. Again, they start with a wide area as you narrow down, and then you get to the point where that's where, ouch, that's where it hurts more. Yes, it can go down. It can also start here. It is a gluteus medius intentional tendinopathy, or it could be just the inflammation of the bursa. And they say, I'm not able to lie on the side. Like the shoulder pain people, they say they can't lie on the side of the affected side. They can't lie on the side. So local tenderness over the greater trochanter. And it's a repetitive trauma from the friction of the gluteus medius or the iliotibial band over the trochanteric bursa. For some reason, a bit more common in the female runners, some of them tend to run on the outer border of the foot. If you ask them to see them, they can run on the outer border of the foot. So, and MR is useful. X-ray to look for calcification or sclerosis on the greater trochanter, but most of the time it may be unremarkable. And you can get an MR which shows a edema around the greater trochanter or a thickened bursa. Physiotherapy, laser and ultrasound, like the tennis elbow, corticosteroid injections for acute pain relief. It gives excellent pain relief. Is touch the bone, withdraw, and into the bursa. And of course, these days we do it on an ultrasound guidance with the help of our pain specialist. Bursectomy is rare and is for refractory cases. Look for associated conditions. This is what I tell the juniors and the patients themselves. It is probably the way they walk, probably the way they're running. It's which puts this extra pressure on the side of the hip. And sometimes it's an intra-articular pathology. That's one more reason why it's better to get an ultrasound, although the diagnosis is clinical by a point tenderness or the greater trochanter. Now, osteitis pubis. Now, I'm really touching on some of the things which can trick you. Pubic symphysis pain. Okay, post-pregnancy, post-delivery is okay. But when it happens in players, particularly in the hockey, the footballers, because that's the superior glide of the symphysis pubis, and it also opens up this way. There's an intra-articular disc and there is an interpubic ligament. And look at how much stretch it goes on as the player tends to kick the ball. So it's not an uncommon problem in the footballers and people who play hockey, and also dancers. You know, the so-called the Aramundi position in the classical dancers. So dancers and people who run. So it's due to repetitive microtrauma again. It's a repetitive stress or overuse injury, and can happen because they have increased the intensity or duration of training too quickly. Faulty foot and body mechanics and gait disturbance. If you really see their running pattern, if you turn them to the exercise physiologists or the trainers, they'll give you a clue. This person is actually walking on the outer body of the foot. They're running with an in-toeing gait. So there's some difference in terms of the body biomechanics. So commonly pain over the anterior pelvic region, localized tendons directly over the pubic symphysis, and it's quite sometimes difficult to differentiate this from the adductor tendonitis or the adductor spasm, which is very common. A very common overstretch injury is adductor tendonitis. And so because the pubic tubercle and pubic symphysis and both are very close, you really need to keep pressing again. Of course, the patient will be pain. So you start from lower down and try to locate where the pain is right over anteriorly over the pubic symphysis, or it's more here in the adductor region. NSAIDs, rest, and pubic symphysis is really difficult to give any meaningful ultrasound or laser therapy. Steroid injections are controversial. I have used, however, in a very symptomatic patient. It does help them with the pain. Most of the time, gait training or read training, give them the proper mechanics and adequate rest. Usually they get over it. Don't get worried too worried about this edema. Of course, you need to keep in mind about any infective reason. It's a non-infective condition, secondary to training. But if you are suspecting any infection, then you do need to evaluate further. One more, again, tricky situation. Sciatica is easy, goes from back to right down, but this is not a typical sciatica, although it presents like sciatica, hence it's called the pseudosciatica. Radiating pain, they come from a burning sensation, and sometimes as they're lying in bed and they're trying to turn in bed, or certain portions of the leg, and that's the clue. It is not a typical sciatica of just radiating right from the spinal region to the foot, and doesn't necessarily always go down below the ankle into the foot, and it's usually more in the hamstring region, and hence it's called the pseudosciatica. And again, when they start to exercise after a long layoff or too short, try to increase the level of intensity of training in too short a notice, and on-toe running. So what we call the FAIR test, which is flexion, adduction, and internal rotation of the hip, can reproduce the symptoms. Flexion, adduction, and internal rotation of the hip, and you put the piriformis sometime on the stretch. There it's exiting underneath the piriformis, the sciatic nerve, hence the sciatica-like symptoms. Nerve connections test can show delayed FNH waves because you're really looking for some a little tricky condition or difficult condition to diagnose. A 3 Tesla MRI will be useful. First things are first, NSAIDs, rest, focus to stretching the piriformis. The physiotherapist has to be instructed as to what he needs to do, and our pain specialist give a very nice ultrasound-guided cortisone injection in and around the piriformis sheath. And of course, in a very rare refractive cases, you do need to explore, and you can even cut the piriformis or just release it. The IT band syndrome can be pain or snapping, very common in the runners and cyclists and dancers. Again, abruptly increasing the duration of running. Sometimes it's because of the prominent lateral femoral condyle and a tight ITB band. So the initial thing is to stretch the ITB band. Stretching the ITB band is quite difficult to teach them. It takes a while. It initially needs assistance, and you stretch the ITB band. And again, some of them have physiological genuine valgum or varum, which increase the Q angle and sometimes a high arched foot. The impingement zone usually is 30 degrees of flexion. Remember, the IT crosses both the hip joint and the knee joint, and it is involved both in flexion and the extension of the knee joint. The Ober test: lock the hip in extension, get the knee to gradual full extension about 30 degrees, and abduct and let it drop down. As it drops down, there is increasing pain on adduction. Rest, NSAIDs, corticosteroid injection. If in a very tight ITB, you perceive at least a good 2-3 months of stretching, Z-plasty is an option. Z-plasty of the IT band can give you the IT band length. Commonest by and large, the hamstring injury. It could be intramuscular, rare. Most of them are muscular tendinous. Usually due to the sudden takeoff phase during running. Proximal avulsions, again, at the ischial tuberosity. Distally, it is more of an insertional tendinopathy around the popliteal fossa. Posterior thigh pain, stiff leg gait. In an acute rupture, it's a very strong muscle. You see extensive, huge ecchymosis. There could be an underlying use of steroid, because someone who's actually done regular fitness and regular training, it is rare to have a complete rupture. So history of steroid use has to be probed into. And this is ischial avulsion of the hamstrings. That's in the MR on the T1. This is changes in the muscle itself. These are partial tears, and you can see some underlying degenerative changes due to chronic overuse. Can take up to 6 weeks to heal, and you need to let them to return to sports only when the strength full, at least 90% of the strength is achieved. Avulsion injuries, yes, you need to repair it. If it's a big sliver of fragment, the rest usually improves with conservative treatment and proper retraining. Sports hernia, anterior pelvic pain or groin pain, of course, do rule out the regular hernia as well. It is secondary due to abdominal hyperextension and thigh adduction. Obviously, male athletes more common than the female. Do check the adductor longus region, check the inguinal region before you tend to put it as a sports hernia. The X-ray, MRI, and bone scan to rule out other causes of symptoms, because the diagnosis can be difficult. As you know, even in some very popular sports person, it has been missed. So beware of it. And for the pain, decompression of the genital branch of the genital femoral nerve is useful. And if there is a hernia, then the routine hernia operation is useful. Snapping hip. Some people don't have severe pain. They complain of discomfort and a popping noise which disturbs them. A popping noise followed by discomfort and the restriction activity. Again, it could be very tricky. Ask them to reproduce it. As they reproduce it, you put your hand around the knee, you put your hand around the hip, because it's the iliotibial or the iliopsoas is common, and the intra-articular, beware of the labral tear. And it needs dynamic testing with an ultrasound, with a good ultrasoundologist can help you to find out in which angle it's actually snapping. And MR can show you, of course, if the tendon is swollen or any other pathology. And the MR also helps you to rule out an intra-articular pathology. It could be a loose body, it could be a labral tear. And usually, sometimes, why it snaps is because of the bony prominence around the trochanteric region or in the distal femur. So snapping hip, noise, try to reproduce it. It takes a while. It takes 2, 3, 4 times. And sometimes they are clever because it happens so frequently, they're able to tell you. Now, I will, what was a big, something was in 2008, is when 2007, when I heard about this, and we were thinking that it was a big buzzword at the time. Oh, hold on, femoral acetabular impingement, FAI, And these two guys have to be credited for most of the work. Prof. Reinhold Gans, I had an opportunity to see him once, and Michael Lenig, he's from Switzerland, and they are the guys who actually, this was a 2008 article looking at current concepts regarding femoral acetabular impingement. It's basically the femur impinging on the acetabulum. The acetabulum has got a huge labrum, and the shape of the acetabulum can vary from person to person, a protrusive acetabuli and normal acetabuli. And what it is whether the two broad things which was mentioned at those stage, whether it's a cam lesion on the femur or a pincer lesion on the acetabulum, which causes the impingement, and the impingement, whether it is one of the reasons for early degenerative changes. It was more like a chicken and egg story, whether degenerative changes causes degeneration in the joint cause the pincer and the cam, or the cam and pincer cause the degenerative changes. Now that's the cam, the bump on the femoral head, and that's with repeated impingement from a pincer, where you can get a dent on the femoral neck. So a bump on the femoral head is a cam, and the prominence of the acetabular margin is the pincer. They also introduced something called the subspinous impingement, which is a very prominent ASIS here impinging on the greater trochanter. But by and large, the two most common is the cam and pincer impingement. That's the pincer is an over coverage of the acetabulum on the femoral head measured by the center edge angle, and this is a dysplastic acetabulum. So the cam, the pincer, and the subspinal. Now that's a cam lesion here. So this is what happens in the pincer. Okay, this is what happens. So that's the pincer lesion there, that one, and you get the femoral acetabular impingement. Okay, and then this is what happens in the cam. Remember, the cam is a bump on the femoral neck, and that what happens in the cam lesion, femoral acetabular impingement. The cam most of the time is in the anterior-superior part of the femoral neck gets involved. The anterior-superior part of the labrum gets involved, and in the pincer, it could be even here in the posterior aspect of the femoral head, posterior aspect of the posterior inferior aspect of the labrum can also get involved. So that's the cam, and that's the previous one was a pincer. And what you do is anterior impingement test, flex the hip, flex the knee, adduct the hip, and internal rotation. And as I told you, this goes to Lenig, this is a provocative test, because in those days, the 3 Tesla MRI was not there. A MR arthrogram was what we all requested, and it was not easily done. And no one thought about it. We all thought, okay, it's pain. Okay, you got OA. No, maybe you got osteophyte. Maybe you got iliopsoas pain. So the diagnostic injections are useful. Whenever the diagnosis is not certain, before you go into a major intervention of removing this cam or pincer, try to rule out other causes of pain by diagnostic injections, the iliopsoas, the SI joint, or the piriformis, depending upon the location of pain. And patient selection is very, very important. There are people who have been written off the sports because sometimes they don't come out very well. They can have tendon injuries, they can have stiffness and everything. And remember, 70% of cam and pincer coexist. And because of repeated impingement, labral tear, you do need to address the labral tear as well, which is by resection or repair. By and large, if it's a small tear, resection, and look at the articular cartilage. And very, very important is the post-procedure rehab, and discuss this prehab. And what does the evidence suggest? Surgical, this is a JBJS article from 2013 about the evidence for treatment of these things. Whether it does really prevent arthritis, we don't know yet. And open versus arthroscopic procedure, again, we don't know yet. But what we know is there's a good evidence for surgical treatment if they are a confirmed case of femoral acetabular impingement. Thank you. There's lots of other conditions which is around, but I touched you on some of the difficult and gray areas. We shall certainly have a discussion if you have, about other conditions. I'll give it back to Dr. Karthik to introduce the next speaker. Thank you once again.
Fantastic lecture on sports injuries around the hip joint. Now can I invite Dr. Senthil sports injuries around the knee joint.
Need to unmute your mic, Dr. Karthik.
You have to unmute your mic, please.
Okay, can I introduce Dr. Senthil to talk on knee injuries in sports?
Hello, everybody. That was a very elaborate discussion on hip pathologies in sports. We come to another important area, the knee, and I would like to touch upon the common injuries which happen in sport. Many of the injuries might be familiar with us because we see it in regular practice. The ones like anterior cruciate ligament injuries, meniscal injuries, these are something which we call like bread and butter of our orthopedic practice. The other thing which I would touch upon is patellofemoral problems, which is also a very, very important part of the knee, and it is also one of the major reasons for incapacitating pain in people involved in high flexion sports, and can actually kind of put them away from pursuing their sport or their passion. Apart from these ligamentous and bony pathologies, I would also like to touch upon certain conditions around the muscles and tendons of the knee, and that would be the kind of a general outline of the topic. Start off with the anterior cruciate ligament injury. As most of us know that this is actually, they occur when there is actually a kind of a twist in the knee joint over a firmly planted tibia. So especially if there is like if it is a football player and he's running on the pitch and his boots get caught in the grass, or if there is any kind of a person kind of twisting him while he's actually kind of keeping his firmly planted foot on the ground, then he can actually kind of give away his ACL. He will feel it as a pop in his knee, and there would be immediate effusion in the knee. So this person will not be able to actually kind of pursue his game, and he'll be actually kind of wheeled away from the thing. This is one of the major injuries which actually kind of put out Michael Owen from his and actually kind of like how Dr. Kosygan had showed up in the slides earlier on, actually made him quite from a high performing athlete, he had to come down to second bench and then had to retire. Now he's one of the main commentators for us. So as these kind of injuries occur, we need to actually identify them. The identification, apart from the history, would be we need to do the clinical examination. The clinical examination is mainly picked up by two or three tests. Apart from the effusion, we normally do the anterior drawers test, where we evaluate the translation of the tibia in relation to the femur when we keep the knee flexed around about 45 to 60 degrees. And when we actually kind of keep the thumb on the tibial tuberosity and see whether there is actually an anterior translation. Depending on the translation and the feel of giveaway, so if there is no firm endpoint, then we actually kind of realize that the ACL is injured. It is confirmed again with the Lachman's test, in which we actually kind of keep the knee in a 30-degree flexion and we do the anteroposterior movement of the tibia over the femur. And again, we look for the firm endpoint. If there is no firm endpoint, if there is a mushy feel, a soft endpoint, which we say, then we confirm the diagnosis of an ACL injury, and we think those kind of situations in which we actually have those patients who are in the mid zone, where we cannot actually kind of make a thing where the patient says that I have a feeling of giving way. Whereas if you have a look at the MRI scans and you look at the sagittal films and you have a perfectly normal ACL, those kind of situations are the cat on the wall situations in which we actually kind of have to put these kind of patients through a course of physiotherapy and rehab to see whether these actually are actually kind of improving and whether they actually will benefit from any kind before we actually kind of give them an option of going for surgery. So we always give them a period of time in which we actually give them a period of 6 weeks to 12 weeks of rehab to see whether they are actually kind of getting good strength in the ACL. But however, if they do not get any benefit, and if the knee still buckles and gives way in spite of exercises to the quadriceps and hamstrings, then we actually kind of give them the option of going for a ACL reconstruction. Treatment for these procedures, as you know, can be open or closed, arthroscopic. Open procedures are not done nowadays. With regard to the arthroscopic ACL reconstructions, most of us are using the hamstring tendons, the semitendinosus and gracilis, and we follow the anatomic ACL reconstruction technique, in which we pass the graft in a hyperflexion of around about 110, 120 degrees. And I as per se use, we do have different kind of fixation options also for these grafts. We use a suspensory fixation for the femoral side, like an endo button, and we use a bioabsorbable screw for the tibia. So rehab protocol for these patients, we normally put them through, my rehab protocol is for the first 2 weeks, I normally keep them in a brace, and I normally allow them to go about with full weight bearing. With regards to exercise protocol, we normally give them close chain exercises and slowly progress them with knee bending activities, so that in around about in a period of 6 to 12 weeks, most of them are actually kind of having fairly good range of movements. However, if many of these patients who have associated medial meniscus tears, if they are having a meniscal repair or something like that, then what we actually do is we actually kind of give them a protected knee bending protocol around about 0 to 60 degrees initially for 3 to 4 weeks, and gradually proceed after that to gain full range of movement. Many of the patients who we actually kind of do reconstruction actually kind of get to a stage where they can jog and run around about 6 to 8 months. So though nowadays the initial thing was saying that the most people could actually resume sports at around about 6 to 8 months. Nowadays, we do feel that many people are coming with re-ruptures, and so they actually say that we actually kind of go ahead with more rehab and put high-profile athletes, keep away from any kind of real good interventional sports for around about 12 months from the time of index surgery. I would go on to PCL injury. PCL injury, again, as you know, is otherwise called a dashboard injury, where you actually have a force in the front of the tibia. So it could be a fall on the knee in which the tibia the force is directed posteriorly, or it could be a dashboard kind of injury in which again the same kind of mechanism. And many of them actually present with bruise at the back of the knee. And though many of these patients actually kind of can get away with conservative treatment, the results of conservative was open, especially if you have a bony avulsion or with associated features, especially because PCL injuries may not be isolated, it can be associated with a posterolateral corner tear or anything. So you need to actually look at the MRI, make sure that you are now looking at the posterolateral corner, look for any avulsion in the region of the biceps femoris or in the region of the fibula head. If you see anything like that, you should suspect a thing, and then you have to check for posterolateral corner injury. If that is the case, then you will have to kind of think about tackling both the posterolateral corner as well as the posterior cruciate ligament to get a good treatment. Whereas if you take a conservative treatment for these patients, especially if they have an undisplaced avulsion of the bony avulsion, and if you think that this thing, you normally put them in a extension plaster for around about 4 to 4 weeks, and after that slowly get them to start movement. However, if you're thinking in terms of conservative treatment, strictly there should not be any solitary hamstring exercises for approximately 12 weeks from the time of surgery. Operative treatment, when you do reconstruction for the PCL, we actually kind of make sure that there is when you're passing the graft, you actually kind of make sure that they say there is a particular area where you call there is a sharp bend. So there's always a reason for this. These people can develop attrition rupture. So you need to make sure that you keep your graft passage very optimal and with adequate length, so that you don't have any kind of attrition rupture in the region of the PCL insertion. With regards to lateral collateral ligament injury and medial collateral ligament injury, these do occur as usually not isolated, but along with an ACL or a PCL injury. The lateral collateral ligament, the origin is from the lateral epicondyle, and it goes right down to the fibula head. these kind of injury, these patients normally get injured if there is any kind of a varus stress. If you get a varus stress and they have a giveaway in the lateral side, then there's thing. But generally, the lateral collateral ligament is very strong, so the injury pattern is very injury occurrence is slightly less. However, if the force is extremely high, like if you have a injury which can actually tear the posterolateral corner, then usually the lateral collateral ligament also goes. Treatment for undisplaced injuries is usually conservative. We normally put them in a brace, and usually the response to treatment is quite good. Same thing in case of medial collateral ligament injuries. As you know, the medial collateral ligament is a superficial and a deep part. The deep part is actually contiguous with the capsule of the capsule and the medial meniscus. The superficial part, however, just lies underneath the gracilis and the semitendinosus and takes its origin from the medial femoral epicondyle and inserts onto the periosteum of the tibia. So, as I was saying, the injury which is most commonly neglected. So, this is a neglected injury, the posteromedial corner injury, and we need to pick it up. It's normally the area where the anteromedial part of the knee, where you have the medial collateral ligament and the posterior oblique ligament. So these patients normally have any kind of a valgus force. If you put it and you extend the knee, you normally have a medial rotation knee instability. So if these cases, if this is the presentation, most of them you should look for other associated injuries like an ACL injury. And if you have an ACL or any other injuries, then we need to address it primarily and also look for the posterior oblique ligament and try to repair it if possible. The more important injury which can occur, especially if you have a posterior cruciate ligament injury, would be a posterolateral corner injury. Usually the nature of the injury is when the knee takes the brunt of the force in a flex position. It's a varus kind of force, and along with that there is an external rotation component. So the chief external rotators of the knee, which you see are the popliteus and the popliteofibular ligament, which normally form a complex which is called the arcuate complex. So that normally carries the static stabilizers of the knee, that is the LCA, the arcuate ligament, and the popliteus tendon. So if these three together are actually kind of injured, then literally they have a chance of opening up of the lateral component if you do a stress view X-ray. So however, but if you do an MRI, you can see the extreme amount of edema which is present in the posterior lateral aspect of the knee, along with, if you can see here very closely, you can see the arcuate sign where you can actually see the fibula head. There is an avulsion fracture which is actually at the level of the fibula head. They can have associated meniscal injuries also with this, but most probably these injuries are associated with vascular component, or you might have an injury to the peroneal nerve because of the nature of the edema, or you can see around the head of the fibula. So you need to keep in mind vascular injury and nerve injuries when you're dealing with posterolateral corner injuries. You should also make sure that the patient hasn't had a dislocation of the knee, though I haven't mentioned anything about dislocation. If the patient has a dislocation of the knee and he has a reduced impact, then you have to have a look at the other ligaments around the knee and make sure that you don't have a multi-ligamentous injury. In this section of the knee, you can actually see that the popliteus is actually kind of edematous, and if you see this, then you are also, again, you need to think about a posterolateral corner injury. And posterolateral corner injuries, usually when they are present, you need to tackle them along with the PCL. The diagnosis, however, you should it is because it is a very commonly missed finding when on initial presentation, when you have a person who's having a problem in his knee, then you have to examine him clinically right from the time he enters your clinic. if he's walking with any kind of a varus thrust, you have any kind of a varus alignment in the knee, then you have to think in terms of posterolateral corner injury. Tests we normally do in the supine position, if you lift the leg with the toes, if there is an external rotation and a recurvatum, then you have to think in terms of the PLC. The other test is the dial test, where you actually kind of bend the knee to 30 degrees and you externally rotate it at the foot. If there is increased external rotation on one leg compared to the other, then we would think in terms of a posterolateral corner. The same test, if it's done at 90 degrees and if is positive at both, then we think in terms of a posterolateral corner along with the posterior cruciate ligament injury. So as I said, if you take an MRI, you normally are able to pick up all these diagnoses, and you have to address this if you need to get good results in your patients. Meniscal injuries are very common. Usually the patient presents with symptoms of pain in the inner aspect of the knee. They also present with clicking noise in the knee. And however, if they have anything like a mechanical impingement, like a bucket handle tear or anything like that, they normally present with a locking of the knee and unable to extend the knee. So this needs to be addressed. So that bucket handle tear, which is thing normally we would take it as an emergency, and we need to make sure that these people are addressed immediately. So as I said, there are different types of tears. You can have a longitudinal tear. You can have a bucket handle tear, which is undisplaced. Most of these people are able to manage with the thing, but they don't have. However, if the bucket handle displaces and the anterior edge goes into the intercostal notch, they land up with locking, which needs to be addressed. Most of these bucket handles we are able to reduce them, and we can actually repair them with meniscal stitches. The results with the meniscal stitches is quite good. People are also using, along with meniscal stitches, fibrin clot, which is helping with the healing of the thing. However, if you have a complex meniscal tear, then most of them, they actually do a partial meniscectomy. So this is just how we are doing a meniscal repair for the posterior horn of the medial meniscus. So I'll go on to patellofemoral problems. This is something which is very common, as I said, in our practice, and this needs to be addressed. You can have problems related to acute trauma. So if you have a person with an injury to the knee, he can present to you with anything from a contusion to a fracture. It could be anything like even if you can have like a patellofemoral dislocation if the person has a tear of the MPFL, or you can have any kind of injury to the tendons, like you can have a patellar tendon injury or a quadriceps tendon injury. So if you can have acute injuries, or you can have something which is, so this is one part of the problem which can affect the patellofemoral joint. The other part of the problem can be because of repetitive use. We can have tendinitis, patellar tendinitis, like a jumper's knee, or you can have quadriceps tendinitis, or you can have something like if the person is like involved in wrestling or those kind of activities, they can have because of too much kneeling, they can develop bursitis, like pre-patellar bursitis in the knee. So these kind of things, which are some things which we have to keep in mind when we are assessing the knee, and based on that we address them. If the person is if an adolescent is involved in jumping activities, and he can present with features simulating patellar tendinitis, which we called Osgood-Schlatter's disease, which is a traction apophysis of the patellar tendon. However, as I said, most of these problems can be treated conservatively. Nowadays, if the person has a cartilage problem or if there is any kind of early degenerative tear, we think in terms of treating it with, initially we used to treat mild problems of the cartilage by offloading the stimulating force. Like if the person presented with chondromalacia or any kind of a softening of the cartilage, then we used to ask them to avoid extreme knee flexion activities, keep the knee in the extension, give them kind of braces, ask them to do physiotherapy, strengthen the vastus medialis obliquus, and those kind of things. Lately, we have also started using stem cell therapy and platelet-rich plasma for chondromalacia and the other kind of thing. If the person has presented with you with a tear in the MPFL causing dislocation of the knee, and if it's if on conservative treatment the patient still has instability, we have to look in. We have to do an MRI, make sure that he doesn't have any other problem like a trochlear dysplasia or anything which is also causing being a secondary cause for dislocation. We need to address both conditions. So by addressing only the MPFL and doing an MPFL reconstruction may not be the ideal things. Nowadays we have ready-made things like double bundle techniques or MPFL, in which we get the isometric point just exactly near the medial epicondyle, and we are able to fix the graft in such a way that the patella is stabilized. But however, we need to make sure that the trochlea is also addressed at the same time. Around the knee, as I was saying, we do have other conditions which can cause problems. Here we can see Rafa, who started having patellar tendonitis at a very, very young age. He started having patellar tendonitis when he was even in the start of his career, when he was around about 21, and that they used to say because of the extreme amount of stress he used to put while going to receive the ball, he started having problems in the knee. So right from 2005, now we are 2020. For the last 15 years, he has been managing with patellar tendonitis. In 2011, 2012, he nearly gave up his career of tennis because he developed tear in his patellar tendon, and following that he was waylaid from the sport for a long period of time. But he has come back in a good way, and he's actually kind of doing extremely well now. So jumper's knee, patellar tendonitis is something in which we actually kind of look into it. Most of the people, they treat it conservatively. We do have people who try injections with lidocaine and dextrose solution. However, the results are equivocal. PRP and stem cell procedures are actually kind of helping with these kind of problems. But however, if the patient is persistently having a problem, excising the necrotic tissue of thing might be a good idea. But however, surgery is only the last option. Osteoarthritis, I did mention about you. Quadriceps tendonitis is just the same as patellar tendonitis. However, if the person has been on steroids and he's a bodybuilder and all, the chances of developing a quadriceps tear is quite high. A quadriceps tear, as you well know, is not a direct injury; it is an indirect injury. So if you have an eccentric contraction of the quadriceps tendon, then sometimes the tendon can tear. The tendon can tear either in the body or it could be if the force is really bad, you can have an avulsion fracture in the superior pole of the patella. Hamstring tears, common in contact sports. Dr. Kosygan has mentioned about it in great detail. As I told you, pre-patellar bursitis is something which we have to keep in mind in wrestlers. ITB syndrome has been discussed by Dr. Kosygan in great detail again. It's very common in runners. It's because of the attrition which occurs between the tight IT band and the lateral femoral condyle, and if it's really bad, you have to address it surgically. Shin splints is something which is not being discussed in too much thing, but it's something which is very common in runners, where they actually present with pain in the inner aspect of the knee. So this is something which takes us back to the initial topic, where we actually kind of have to start conditioning the person before he starts doing long distance running. So if you don't condition the body to actually kind of do long distance running, then the chances of you getting injury to the knee is very common. So this is something which we call the medial tibial stress syndrome. So actually, if the person is having pain in the medial aspect of the leg while doing running for long distance, then we have to actually investigate it if it's not going away. So usually, if you see these people that their running distance slowly starts getting lesser and lesser, and they come to a point where they cannot do any much running. An MRI will actually kind of give the diagnosis if they have bony edema or anything, or even a bone scan can actually kind of throw light into this. So you need to keep this in mind when you have a runner who has come to you with a problem of pain in the. Thanks a lot.
Thank you, Senthil sir. Can I invite TV Raja sir to talk on sports injuries involving foot and ankle?
Audible? Am I
Yes,
audible?
sir, you are
Yes.
audible, sir. You are audible.
Yes,
Your
sir.
presentation
Yes,
is
sir.
also.
Okay. Saturday night. Normally, everybody is busy. Now, probably Synapse and group are trying to keep you busy, and we are trying to re-educate you before you go to your clinics back in about a week's time in this corona era. So now we see about sports injuries in and around foot and ankle. You've heard a lot about all injuries right from your shoulder down to your knee. And I would like to keep it very crisp and precise. I don't want to bother you of too much of talking. So I'll be talking about Achilles tendonitis, posterior tibial tendonitis, plantar fasciitis, and ankle sprain, stress fracture, as you all know, and turf toes. I'll be very precise. So as Kosygan was telling you, what is tendonitis, tendinosis, and tendinopathy? This is what Google says. Tendinosis is a chronic tendon injury with degeneration at a cellular level, and there is no inflammation. Tendonitis, you have inflammation. Tendinosis, there is no inflammation, there is degeneration. Tendinopathy, there is a chronic tendon injury, but you're not worried about etiology. When there is a chronic tendon injury, then it is called tendinopathy. So this slide, I think actually Kosygan has already shown you. This is a normal cylindrical shaped tendon. When there's a lot of stretching, there's a lot of changes in the tendon, and it goes for degeneration. Here you can have abnormally shaped tendon due to compression. This can be because of bony compression, or this can be because of stretching, overstretching, and lack of rest and nutrition. What is the histology? Normally, when there's an osteotendinous junction, when I'm talking about Achilles tendonitis, there are only three things there. One is bone, fibrocartilage, and the tendon. So it is, as you all know, tendon Achilles is formed by the tendinous contributions of the gastrocnemius soleus complex. The tendon length is about 15 centimeters, and the tendon spirals along about 30 to 150 degrees towards its insertion into the calcaneus. And it is the same tendon that it gets covered and it forms as the plantar fascia. So there's a watershed zone about 2 to 6 centimeter proximate to the calcaneus, and this is the place where normally it goes for tendonitis, tendinosis, and tendinopathy. Stage 1, you can call it as tendonitis. When you take a proper treatment, it is reversible. Tendinosis, you go to a good pain therapist, orthopedic surgeon, a good rehab, then you get back to normalcy. When it is tendinopathy, When it comes to last stages, then either your PRP, your BMAC, or you'll have to go to a surgeon for getting it corrected. What are the clinical features? It's a triad of pain. You have swelling around the localized area. It can be diffuse or localized. Early stages, it is localized. Later on, when it turns chronic, it becomes diffuse. Impaired performance, which constitutes the tendinopathy. What is the etiology? It is because of repetitive traction forces, whichever tendon you take. When you're talking about Achilles tendon, it is mainly because of repetitive traction forces there. It can be because of flat feet, pescavers, obesity, poor training. It leads on to degeneration, attrition, mechanical and chemical irritation there, and chronic inflammatory response goes on to spur formation and calcification. So normally what do you see? You can see here, this is the tendo-Achilles getting inserted there in the calcaneum. Here, this is your retrocalcaneal bursa here, and this is your retrocalcaneal spur that grows there. This point is called your Haglund bump there. This is the posterior calcaneal tuberosity which gets inflamed. There is an impingement on the tendon where you get it. So the tendon gets first inflammation when it is tendonitis, then it goes for repetitive injury, then you have tendinosis, then further it goes in for a tendinopathy. Here, this is the X-ray, that was the MR picture. Here you can see a calcification of the tendon there. This is your Haglund bump here. What you're seeing is the Haglund bump. The tendon goes there. Here, there is impingement exactly here. This is your site of the retrocalcaneal bursa which gets impinged. So, conservative treatment is rest, ice, NSAIDs, exercise. What are the exercises you can do? You can do a calf stretch, eccentric strengthening, and bilateral heel drop exercise, single leg heel drop exercise. Normally, what you do is supportive shoes where you can give a heel raise. Normally, for my patients, I would advise them to go for 1-inch heel raise. So what normally happens is tendo-Achilles is relaxed, so that you avoid your impingement of the tendo-Achilles on your retrocalcaneal bursa as well as on the retrocalcaneal spur or the Haglund bump. Now, extracorporeal shockwave therapy for the last 7 to 8 years has been proved to be very good. If it does not giving you good results, then you'll have to opt for a PRP. Previously, people were giving cortisone injections. Why I have not included this is cortisone creates a lot of chemical reaction, and if you're not very good trained to give it, if you give it into the tendon, there is rupture of the tendon. So PRP gives better results, and BMAC or PRP followed by rest and good exercise in rehab gives you very good results. Next, you go on to posterior tibial tendon dysfunction, tendinosis and tendinopathy. Here you can see here, what you see is your hind foot going in for your valgus deformity. You can see a flat foot. This is the medial surface where you can see a flat feet here. Too many toes sign. Normally your tendo-Achilles has to be straight. On the lateral side, normally you must be able to see only one toe, but here you are able to see 2 to 3 toes. So when your hind foot goes in for valgus, then you see more toes on the lateral aspect, which is called as too many toes sign. This is the first thing when you see a posterior tibial tendonitis. Normally medial side near the navicular insertion, you see a swelling, pain, and early arch collapse you will start seeing, and patient says that she or he has got a lot of pain. This disease is more particular in females, but normally in sports injuries, when there's an avulsion of the posterior tibial tendon from the navicular, you see it here. When it is avulsion, your PRP or BMAC is not useful. You will have to go for reinsertion of your posterior tibial tendon. Normally what happens is avulsion is a little bit of rare except in sports injury, but what normally happens is when the posterior tibial tendon winds around your medial malleolus, there's about 1.5 centimeter where the tendon is little hypovascular and there's an excursion of the tendon there. So when your hind foot goes in for a valgus, there's a lot of pull here on the tendon, and that is the reason your tendon goes for degeneration. And another reason for this, it is because of your talotarsal mechanism. Nothing but talus is the middle bone transferring your load from the tibia down to the calcaneum. If suppose the talus and calcaneum are not sitting properly and there is a small subluxation, the first ray or the medial column, right, starting from your talus navicular medial cuneiform, there is a push from the talus down to your first metatarsal, where your navicular is pushed down by your talus, leading on to stretch on the posterior tibial tendon, which creates a load, more load on the posterior tibial tendon. And along with this, when there's sports injury, the damage is very, very high. Here you can see the straight foot here, and here you can see a foot with a posterior tibial tendonitis there. Here you can see the arch getting slowly collapsed. This is the posterior view. You can see the hind foot going in for, this is the normal foot, and this is the abnormal foot with a hind foot valgus. When you see a patient, ask them to look at you in front with a barefoot standing, examine them from a distance. Now corona, you cannot go very close, you can look at them and you can say that your hind foot is going into valgus or not. Here this is a normal foot here, and this one is your flat foot. In a chronic injury of posterior tibial tendon, this is the presentation grade 3. But in early stages, this is the place where they normally present. It is exactly just 1 inch anterior and down to your medial malleolus is the area of pain. So what is the etiology? It is trauma, systemic inflammatory, impingement in the tunnel, hypovascularity of the tendon, as I told you. When it is winding around the medial malleolus, about 1.5 centimeter, there's a hypovascular area. So this is the excursion, about 1.5 centimeter around the medial malleolus. There is a static supports become overloaded, as I told you. When there's the alignment between the calcaneum and talus is offloading, then there is a pressure on the medial column, that is your talus navicular down your first metatarsal. The load transfers and it pushes the posterior tibial tendon. So there is a continuous overload on the medial aspect, as well as there is an insufficiency of your spring ligament, talonavicular capsule, and the plantar fascia, which leads to a painful flat foot, and there is a hind foot iguanus and a valgus deformity, which leads to midfoot collapse and abduction. So there is, which leads on to tenosynovitis, which is acute stage. As it progresses from stage 1, stage 2, it goes on to a permanent deformity, equinus contracture, and a too many toes sign, as I told you, will be seen. Classification says type 1, 2, 3, and 4. So up to 2, it is manageable with your PRPs and your BMAC. When it goes on to a rigid deformity, then corrective procedure is required. And for stage 1 and stage 2, treatment pattern will be spoke by Dr. Vanmathy, where she's going to talk about your PRP and your BMAC injections. And on 3 and 4, it is corrective surgery, where you do corrective osteotomy and correct it. Normally, treatment for type 1 and type 2 is non-operative, NSAIDs, injections, Vanmathy will be talking on. 3 and 4, it is operative debridement, calcaneal osteotomy. And for 2, you can use your heel cups, and you can use AFO, ankle foot orthosis, which gives you good relief. The next topic is plantar fasciitis. What are the symptoms, causes, diagnosis, and treatment? So as I told you, this is the Achilles tendon getting inserted in the calcaneum, Then it starts as the plantar fascia get inserted at the 5 metatarsal heads down. So when there is an acute strain there on the tendon, then it is called tendonitis. Then it goes for tendinosis and tendinopathy when it becomes chronic. Normally, plantar fasciitis is a self-limiting disease. So normally they say early morning first step pain, and there is an inside arch pain and a central heel pain. These are the normal symptoms what they talk about. So normally what the treatment pattern is: topical treatment, good shoes, stretching exercise, medication. Surgery, very, very last option because it's a self-limiting disease. So you have to avoid barefoot walking. You'll have to give them a good rocker bottom padded shoes. These are night splints and these are heel cups which are regularly used. So the mini invasive procedures, you can see here radio frequency, what they do regularly at Synapse. Here these are PRP injections. This is the site of the injection. This Dr. Vanmathy is going to talk briefly on that. Next, I'll be talking about ATFL injuries, which is one of the commonest injuries in sports injuries. What is a strain? Injury to the muscle or tendon as a result of sudden pulling them too far. A simple overstretch is a sprain. So this Kosygan has already told you. So ankle sprains, it can be a high ankle sprain or it can be a low ankle sprain. When you talk about high ankle sprain, it is going to be a syndesmotic injury. When it is a low ankle sprain, which is about 90% common, is ATFL with a CFL injury. So what is the pathophysiology? It is mainly about inversion type of ankle injury on a plantar flexed foot. And recurrent ankle sprains can lead to functional instability. Other associated injuries can be OCD, commonly we call as osteochondral defects, and peroneal tendon injuries. So normally grade 1, there is no ligament tear. So we call it a sprain. Grade 2 is stretch without a tear. Grade 3 is a complete tear. So main symptoms: pain on weight bearing, there is swelling and ecchymosis, recurrent instability, catching or popping sensation may occur following recurrent sprains. Focal tenderness along the ATFL and swelling over the involved ligaments and anterior drawer, and there is a complete tear, is positive. The x-rays, normally any foot and ankle x-ray, I would prefer weight bearing x-rays. They are standard, and you'll have to look for anterior talar translation, and when you take a stress view, you can see the talar tilt there that's happening in stress view. Treatment: Rice protocol, elastic crab bandages. You can give compression bandages initially when it is acute, and later on go for ankle immobilizers, followed by rehab and physio. Operative only when it is complete tear. When you confirm it with an MRI, you go for repair of your ATFL and CFL. Thank you. All your questions on foot and ankle injuries will be answered in the questioning session, because I think you'll be tired of hearing the too much of talk on all injuries right from 5:30. So I would not like to bother you. I've cut down some of my slides because Dr. Kosygan has talked to you on detail about everything. Thank you very much.
Thank you, Raja sir. Short and sweet, very nice talk on ankle foot injuries. So last but not the least, I would like to call my colleague, Dr. Vanmathy. She'll be talking on PRP BMAC injections in hip, knee, and ankle. I've urged her to do it pretty fast, so we'll be done in about 10 minutes time. Dr. Vanmathy, she does predominantly most of the ultrasound guided procedures in the clinic. So Dr. Vanmathy on lower limb pain injections.
A very good evening, one and all. I think probably we are running short of time. I'll make it quick. We all know that tendon and ligament injuries, they contribute to almost 45% of the musculoskeletal injuries. As far as the lower injuries are concerned, the major injuries are Achilles tendon injury, Patellofemoral plantar fasciitis. And if we take the PRP versus BMAC, PRP is best suited for ligament, tendon, peripheral nerve, and muscle injury. PRP can be used either in the acute phase or as well as in the chronic phase of the injury. And bone marrow aspirate concentrate, as we all know, it is costlier, so the evidences are limited. And who are the best candidates for the PRP? Any patient with an injury, history of injury, physical examination and imaging, MRI or the ultrasound, confirming the diagnosis of peritendinitis, tendinosis, tendon tear, muscle tear, who have failed to respond to conservative treatment, or who want to hasten the recovery in the acute phase of injury, or who want to delay or avoid surgeries. In such patients, we can go for PRP. The proposed healing mechanisms being improved vascularity, decreased tendon repair time, improved fibrinization, increase in the tensile strength, and potential to restore functional plasticity. Coming to the common hip pathologies where we use the regenerative injection, it has already been extensively discussed by Dr. Kosygan, sir. The common pathologies wherein we use are the Trochanteric Bursitis or gluteal tendinopathy, adductor tendinopathy, rectus femoris tear, which is uncommon, and the labral tears. The common knee pathologies that I'm going to talk are the patella tendinosis, patellofemoral joint arthritis, and the ankle and foot pathologies like Achilles tendonitis, posterior tibialis tendonitis, plantar fasciitis, and ATFL tears. So this is the International Olympic Committee position on the PRP. We have to use it with caution, with proper, we have to document it why it is being used, and permission has to be obtained. And isolated growth factors injection are prohibited, and intramuscular injections, this position was in 2010. Probably at that time they prohibited intramuscular injections till 2011 because there are more evidences to, we are lacking more quality evidences. Coming to the gluteal muscles attachment on the greater trochanter, we know that one of the commonest causes for lateral hip pain being the gluteal tendinopathy or the trochanteric bursitis, which is commonly called as, which is commonly identified as bursitis. The patients usually have a pain on the lateral hip, which is, and they will be unable to lie down flat on the lateral aspect. If you look at the attachment of the muscles, the gluteus minimus gets attached to the anterior facet. The gluteus medius is attached to the lateral facet and the supra-posterior aspect, and the gluteus muscle is the major bulk on the top of it. So if you see this being the anterior facet, this muscle is the minimus, and this is the medius muscle, and this bulk is the gluteus maximus. The bursa, this thin area, black area, is the bursa. If there is a bursitis or inflammation, if the patients are having severe pain, probably we have to look at the gluteal muscle for any tendinopathic changes. And if there is no associated tendinopathy, we can go for a cortisone injection here. But if in case it is recurrent or it is not amenable to treatment, then probably we have to look for any gluteal pathologies, and we need to address it with the PRP injection. And for this, the patient has to be placed in the lateral decubitus position. We can use a linear array transducer. In obese patients, probably we can use a curved array transducer. And we have to do a longitudinal scan. The anterior facet shows the anterior facet is the gluteus minimus, and the posterior facet or the lateral facet is the gluteus medius. So if there is any tendon thickening, altered echogenicity, like a hypoechoic area, loss of fibrillar pattern, tears, anything that is seen, then probably we may have to do a MRI, document it, and then we can go for a PRP injection. So this is how we do the PRP injection. We have to do a transverse scan over the greater trochanter, look at the defect that is there on the gluteus medius, probably the targeted area we have to reach, and then we have to inject the PRP. Coming to the evidences for the PRP versus steroid and gluteal tendinopathy, patients with chronic gluteal tendinopathy, or for more than 4 months, with clinical clinical and radiological examinations, they achieved good clinical improvement at 12 weeks when treated with a PRP injection. In fact, this study is a prospective follow-up study, and it shows ultrasound-guided intratendinous PRP injections proved to be an effective treatment option for gluteal tendinopathy. But still, well-powered RCTs are warranted to confirm our findings. Coming next to the adductor tendonitis or the athletic pubalgia, there is a persistent groin pain due to repetitive microtrauma. Sometimes the diagnosis can be complex. It may be just insertional tendinosis. There can be any alterations in the muscular architecture of the adductor longus muscles. The insertional tendinopathies are the most common, but we can do a diagnostic injection over the pubic tubercle to rule out any tuberculitis, and then probably we can go for a PRP injection if we see any pathology in the adductor muscle group. So this picture, we can see a longitudinal scan, a transverse scan on the pubic tubercle. We can see 3 muscle groups. The topmost is the adductor longus, the adductor brevis, and the next one is the adductor medius. Probably what we when we do the scan, if we see any altered echo texture in the adductor longus muscle, then we can go for a longitudinal in-plane approach via ultrasound, and we can go for a PRP injection. Though in the initial phase we may be going for a cortisone injection if the pathology is exactly on the pubic tubercle. If there is a tendinopathy, then we can go for a PRP injection. The rectus femoris tear, sudden forceful eccentric contraction of any muscle, like contraction of the rectus muscle, as in kicking or sprinting from a standing position, can cause tear in the muscle, wherein PRP can be used. Coming next to the knee pathologies, it has already been extensively discussed by Dr. Senthil. Here, I'm going to concentrate only on 2 pathologies. One is the patellofemoral joint arthritis or the chondral defect, and the other one is the patellar tendinopathy. Here, if you see the long axis view of the suprapatellar area, this is the quadriceps tendon. This is the normal joint. The quadriceps tendon gets inserted onto the patella. This is the suprapatellar pad of fat, and this is the prefemoral pad of fat. Actually, we can go to the transverse ultrasonogram. Here we see the patella. This area is the suprapatellar recess, and it is just beneath the patella. So we can go on a transverse ultrasound and then go in plane, reach the area, and then we can give PRP injections there. Probably the PRP injection is set to repair the chondral defects beneath the, as in chondromalacia patella. There can be cartilage defects. It can repair the cartilage defects. Coming next to the patellar tendinopathy. Patellar tendinopathy has been extensively described. It is called as the jumper's knee. It is one of the most difficult conditions to treat. Here, there can be defects in the patellar tendon per se, or there can be increased vascularity underneath the tendon. The repeated evidences are there to prove that PRP is quite effective, but we may need more number of shots, like more than 2 or 3 shots of PRP. And in addition, probably we have to continue with the exercises and other therapies which has been described. Here you can see this is the infrapatellar area longitudinal ultrasound. This is the patella. This is the patellar tendon which gets attached to the tibia, and this is the Hoffa's fat pad. The injection has to be, if there is a defect inside the patellar tendon, probably we may have to give an injection into the patellar area, like into the patellar tendon. If there is hypervascularity beneath the tendon, probably we may have to give PRP deeper to the patellar tendon. Coming next to the Achilles tendinosis, all these pictures might be familiar because most of these pictures Dr. P.V. Raja sir has also showed in his presentation. The Achilles tendinosis is one of the most common cause for injuries in runners. Probably the overpronation of the foot, and because of the watershed area just 2 to 6 centimeters above the insertion onto the calcaneus, the ruptures and tendinosis are more common there. Sometimes there can be insertional tendinopathies at the calcaneal level as well. This is how we need to position for an Achilles tendon injection. The patient has to be position prone onto the edge of the table. This is a longitudinal ultrasound view of the Achilles tendon. You can see the calcaneum here. The Achilles tendon is very smooth and a smooth fibrillar pattern with attachment onto the calcaneum. You can see some small anechoic area that may be a bursal fluid which is seen there, but it is normal. This is the pad of fat which is seen posteriorly. See, sometimes there can be, here if you see in the mid Achilles tendinosis, this is the watershed area where the vascularity is compromised, resulting in tendinosis in that particular area. What happens if the person strains a lot, suddenly there can be rupture of the partial rupture or complete rupture of the tendon at this area. Sometimes the pain may be because of a retrocalcaneal bursitis with inflammation. If in case of a retrocalcaneal bursitis, we can go for a single shot of steroid injection into the bursa. If in case of a tendinosis, it is better to go for an ultrasound guided PRP injection. So this is how the PRP injection is done. We can see there is a hypoechoic area in the tendon, and we need to do the ultrasound. Under ultrasound guidance, we need to reach that particular area and then fill that area with the PRP. As far as the evidences are concerned, this study shows that repeated intratendinous injections of autologous PRP, they provided good results as far as subjective assessment, level of sporting activity, and time to return to sport is concerned. This study is a prospect, this study, the follow-up was for a longer period, and the results are consistent. But however, the recovery was slower in patients with longer symptom duration and lesser pre-treatment functional levels. Coming next to the posterior tibialis tendinosis, it has also been extensively described by Dr. TV Raja sir. I'm not going into the details. If you see the ultrasonogram behind the medial, if you do a scan behind the medial malleolus, these are the structures you see. This is the tibialis posterior tendon. This is the flexor digitorum longus. So if you turn the probe so as to make it as a longitudinal view to visualize the tibialis posterior tendon, you will be visualizing the tendon like this. So if the fibrillar pattern is adequately maintained and there is no hypoegenic area or discontinuity of the fibrillar pattern, then we take it as that there is no tendinosis. If in case there is any narrowing or peritendinosis changes, then we can go for a PRP injection. Coming next to the plantar fasciitis. For the plantar fasciitis, I'm not going into the pathological details. There may be, if you look at this picture, this is a patient who has an abnormal plantar fascia. There is a plantar fasciitis. This portion of the plantar fascia, which gets inserted at the calcaneum, if you look at the dimension, it seems to be more than 4 millimeters. And there are hypoechoic areas. The smooth pattern is missing. So you can always compare it with the other normal side, and then probably if it is abnormal, then we can go for within the plantar fascia, we can go and inject PRP. So we can also do a transverse scan, a short axis scan, and you can see there is this side it seems to be normal, and on the other side there is thickening of the plantar fascia. The central cord seems to be thickened. These patients, injecting PRP will be beneficial for them as long as we take care of the rest of the parameters like the foot, the orthosis adjustment, all those things, the footwear adjustment, all those things need to be addressed in addition to the PRP injection. So the injection technique preferred approach will be the patient must be lying to the side with the symptomatic side down. Alternatively, you can also make the patient prone and with the leg hanging with the foot hanging outside, and then we can go in a short axis in plane approach and inject PRP into the defective area. So to conclude, PRP treatment with ultrasound guidance is easy and accurate, and it is definitely not a placebo. It is much better than a placebo. And more than one injection of PRP may be needed. It definitely hastens healing, reduces pain, and improves functional outcomes. So as far as sportsmen are concerned, they require early recovery. So early treatment will result in early recovery for sportsmen. These are my references. Thank you.
Thank you, Dr. Vanmathy. So fantastic lecture on lower limb PRP injections. We are done with the lectures. If there is any question and answer from the audience, we are happy to take it. Are we going to be getting, I know it's pretty late and we've overshot time. So are we going to get any question and answer? By any chance, did the audience give us any questions? So maybe we'll take one or two questions quickly.
Sir, the comments panel is accessible to you.
Where?
The admin login, you will have a comments panel in which the questions are there.
Okay. Right. 1 second.
Can I read one of the questions?
Yeah, please.
Yes.
Start reading one by one, and we'll be taking up maybe 10 questions, 20 questions. You can take up. We can be very fast.
What
Kosygan will be busy.
The first question is from Dr. Ramakrishnan, who has asked what is the non-invasive treatment for trigger finger?
Okay, trigger finger. Okay, you will have to do regular massage for your finger, morning and evening, hot water fermentation and stretching exercises. And you can use moisturizing creams or gel to mobilize the joint and exercise. And probably go to a nearby physiotherapy center and learn the exercises and do it regularly. And NSAIDs will help you if he is wishing to take NSAIDs. And best advice would be to meet a nearby orthopedic surgeon.
The next question is from Dr. Anand, who has asked, how do you choose between ice and heat therapy? What are the specific indications for each? How do they work?
Good question. Okay. I will answer, then probably Kosygan also will give you, because he's been working in a lot of sports clinic. Ice, when it is an acute injury, I normally prefer ice therapy. And in chronic pain, you can use heat therapy. Kosygan.
I will let the pain specialist take it.
Yes.
So probably if there is too much inflammation and we are talking more about an arthritic joint, the icing is better. And if you're essentially looking at muscle spasm, back sort of injury, I think heat may be better. But again, sometimes you do have patients who say that I feel better with this. So if they do, then let them go ahead with that. But generally, joints icing is better. And for muscle, back pain, the heat seems to work well.
Another question has come from Dr. Ramakrishna. It goes like, people tend to sleep on one side with flexed arm and putting their weight on one side and come to us with chronic shoulder pain. What to do for them? Second question, why both CT and MRI are for the same patient?
Senthil KamalaSekaran. Unmute your mic and talk. Senthil, shoulder.
Yeah, can you repeat the question?
Just a second, sir. People tend to sleep on one side with flexed arm and putting their weight on one side and come to us with chronic shoulder pain. What do you do for them? Second question is, why both CT and MRI for the same patient?
So the first part of the question is, when you're lying on one particular side, you are putting enormous pressure on your structures on that particular side. So the chances of getting inflammation on one particular side is higher. the usual cause for night pain, as I mentioned in the talk, was impingement. So probably if you are in the younger age group, impingement can be of three categories. If it's earlier in a younger patient, then the treatment is only conservative. You don't need to do any investigations for that. However, if you have a chronic impingement syndrome, then for that we might need to rule out other factors which are causing the reason for the pain, which might be an attrition kind of a rupture of your rotator cuff. For that, we need to do an MRI. The CT part is not required, because if an MRI is equally effective in showing your structures around the shoulder joint quite well. The CT might be helpful only if you are suspecting any kind of fractures in the region. Like if you had a fall, you're suspecting a greater tuberosity fracture or something like that, in which case you might be in a position to take a CT scan. But otherwise, a CT scan is not indicated.
Next question.
Sir, the next question is by Dr. Vivek. He has asked that legal implications of pain management in sports injury.
Dr. Karthik.
Okay, so 2-3 things you have to keep in mind. Obviously, I told you in my talk that it has to be a multidisciplinary team. So it may not be a bad idea that if your diagnosis wise you are not very sure, you have to confirm your diagnosis and you go ahead with the conservative or the appropriate management. At any point of time, if you think these patients require a surgical opinion, you have to get the orthopedician involved. I think legally it is allowed for a pain physician to treat these patients conservatively. And if you think the patient does not require any surgical intervention, he can go ahead with the steroid shot or the PRP shot. So conservative management, pain physicians legally are allowed to go ahead and do. If you think a surgical part is there and the surgical treatment is involved, please involve the orthopedic surgeon or a sports physician.
Next question.
Okay, sir, this is the final question I am presenting. The question is, currently I am doing my residency PMR. What are some of your personal recommendations for specialization in sports?
Dr. Kosygan, please.
Currently doing residency in PMR, what is your personal recommendation for physical medicine and rehab, MD in PMR?
Too much of rehabilitation. You need to hone your skills in being able to assess these patients as to the history and findings, and it takes a while. It takes the sometimes to know which sports causes which problems.
We are not able to hear, sir.
Can you hear me now?
Yeah, we can hear you now, sir.
Can you hear now? Echoing.
Can you hear Dr. Kosygan now?
No, sir, we are not able to hear.
Hello. Hello. Yeah, I can hear.
You can hear. We are not able to hear.
Oh, this one.
Probably increase the volume.
Hello.
Yeah.
Yes.
Yes. Okay. Yeah. Basically, yes. You need to gradually, you can start off being a lower limb or upper limb rehab person and acclimatize yourself to some common condition involving the certain sports, And first of all, you need to be able to thoroughly assess them. That is what most physio rehabs do. From head to foot, they assess them. see what's the sports involved, what are the training techniques, and you do need to make yourself an apprentice with some of the sports rehab person, because a lot of this is hands-on experience, some theory, but a lot of this is hands-on experience. So you need to attach yourself to a sports rehab center. And as I told you, initially you can focus on a lower limb or upper limb, and then read through various protocols based on which you can form your own protocols once you've done enough, once you've gained enough experience. So it's mostly hands-on, listening to the sports people, taking good history and good assessment. First, you need to be okay with the assessment, and only then you can implement what techniques you want to use or what kind of exercise you want to offer them.
Okay. See, you can tell all the viewers to send the questions to Synapse, and probably we'll send them the reply. Or anybody wants to come on WhatsApp, they can come to Synapse, and then we can revert back.
Yes, sir. Probably final comments by Dr. Karthik.
Yeah.
Yes. First of all, I would like to thank all the speakers, Dr. Kosygan, Dr. TV Raja, Dr. Senthil, Dr. Vanmathy, for giving their valuable time for the sports medicine webinar. So thank you to the speakers. My thanks to Intas for sponsoring the whole event. I know we overshot time and they had to extend it in their studio. So my thanks to Intas Pharma for helping us with the Zoom and coordinating and making the program popular. So pretty happy with the, lots of delegates messaged me and said the program is good. I had lots of WhatsApp messages. We crossed somewhere around 250, 300 delegates. So thank you very much. So if in case you do have any more doubts or something, you can get in touch with us. If you want the email is synapsepain@gmail.com. Or you can see the website, which is synapsepain.com, and call us or WhatsApp us. So we are always there for you. So thank you very much. Thanks to all the speakers. Thanks to Intas. Good night. Thanks for joining us.
Thank you, guys. Thank you very much.
Thank you so much on behalf of Intas Pharmaceuticals.
And a special thanks to Durai. I think he is there with his unmute mic. Thanks a lot to Durai. Thank you, guys. Yeah, Durai. Thank you very much.
Thank you.
Okay, Senthil, thank you in Madurai.
Thank you.
Madurai in his busy family schedule has joined us, so I thank Senthil there. Somehow we escaped out of Chennai and reached Madurai. I don't know why.
Thank you. Thank you.
Okay.
Thank
bye.
you.
I convey my sir, this Chandraketu this side, finally signing off. Thank you so much, all the speakers.
Thank you.
And all the delegates also who have been participating in this wonderful webinar, which was a little comprehensive. And I hope that Synapse can partner with us in future more programs like this.
Yeah, we'll do. We've already partnered, boss.
Yeah,
we'll
so
again,
we can expect some more programs on some other topics. And,
until Corona is there, we are going to partner only in this.
Yeah. Thank you, sir. Thank you so much.
Thank you.
From all of us at Intas, a very good night. Have a safe time at your place. Thank you, sir.
Thank you.
Stay home, stay safe. Bye-bye.
Thank you, sir.
Thank you.
Bye.
Support Sham.